calling our June 4th Virginia Board of Health meeting to order. I'd like to welcome everyone. Before I get started, I want to say a huge thank you, particularly to Alex Jansen, Mai Lamb, Joe Hilbert, all the folks who have worked so hard to get us online and up and running. This has been no small endeavor, and the kind of work those folks have put in behind the scenes, they have done all the heavy lifting. And if I left out anybody down at the Madison room, thank you. Thank you so much for all that you've done for us. I'd like to let everybody know that this meeting is being conducted in a completely virtual environment and is being recorded. There are several things that we'd like to review before getting started. First, the name of all the board members along with the constituency that they represent are displayed on the screen. In addition, there are several staff members from the Virginia Department of Health and the Office of the Attorney General who have physically assembled at the Madison Building in Richmond. And to comply with the governor's order on social distancing to comply with the governor's orders on social distancing and masks and to limit the spread of COVID-19, they will be wearing face coverings and sitting a minimum of 6 feet apart. The list of all staff members participating in this meeting is displayed on the screen, and several of these staff members are participating virtually. Lastly, all votes that are taken by the board during today's meeting will be roll call votes, and I will be restating the names of the members who make motions or seconds. Members, you should know that while we can see each other, citizens who are viewing the meeting cannot see us. So you may want to say, for example, this is Linda Hines and I move that, or this is Anna Jeng and I second that motion. So it's really clear at all times who's doing what. Attendees, you will not be able to unmute yourselves. When we get to the public comment period, you will be unmuted by the host if you've signed up to speak. With that being said, Ms. Jansen, please call the roll. And so I guess, Alex, when you call the roll and report that there's a quorum, each person can tell you that they're here and what their role is.
All right. We will start. Mr. Kreitzer.
I'm here and I'm representing Emergency Medical Services.
Thank you. Mr. East.
I'm here representing the nursing home industry.
Thank you. Mr. Edmondson.
I'm here. I represent corporate purchasers of healthcare.
Thank you. Ms. Hines.
Here, and I am representing managed care health insurance plans.
Thank you. Ms. Harrison.
I want to know what you're doing about broadcasting this pandemic time.
Catherine, we can
Ms.
hear you.
Harrison.
Have you called me?
I was just saying
Last
because
call for
we can hear you.
Oh, I don't think Ms. Harrison's here.
Keep going.
Next is Dr. Jang.
I'm here. I represent public environmental health.
Thank you. Dr. Kinzer.
I'm here representing Nursing in Virginia.
Thank you. Dr. Klein.
I'm here and I'm representing the Medical Society of Virginia.
Thank you. Dr. Miller.
Hi, I'm here and I'm representing the Virginia Dental Association.
Thank you. Ms. Pritchard.
I'm here. I'm representing local government.
Thank you. Dr. Puritz.
Present and representing Medical Society of Virginia.
Thank you. Dr. Schuler.
Jim Schuler's here representing the Virginia Veterinary Medical Association.
Thank you. Ms. Waddell.
I'm here and I'm representing consumers.
Thank you. And Ms. Whipple.
Present, representing the hospital industry.
Thank you. Madam Chair.
Alex, at this time, And there is a quorum. Thank you very much. At this time, Mr. Hilbert will now review today's agenda.
Well, good morning, Madam Chair, members of the board. The agenda for today's meeting is displayed up on the screen. First item will be approval of the December 12, 2019 minutes. And I would say that, just to remind the board members, that all of the items on the agenda were sent to you previously via email. So you should have all of those items for your review. Following approval of the minutes, Dr. Oliver will provide the commissioner's report, which will be focused on an update on the COVID-19 response in the Commonwealth. Next item will be the regulatory action update that I will provide. We then have a break scheduled. Following the break, we have a public comment period. And before I go on with the remainder of the public comment period, just want to remind people how the public comment period will work. We have a public comment period at each board meeting. When registering for this meeting, there was an opportunity for members of the public to sign up to speak. The list of persons who signed up to speak was finalized at 7:30 a.m. this morning. Each person who has signed up to speak will be called in order, along with the name of the next speaker who's on deck. Pursuant to the board's public participation policy, each speaker will have a maximum of 2 minutes in which to speak. There will be a countdown timer, a 2-minute timer that appears on the screen, and a bell will ring when the 2 minutes has elapsed. If that bell rings while the person is in the middle of a sentence, they will be allowed to complete that sentence, and at that point the speaker will be muted, and the name of the next speaker will be called. Going back to the agenda, following the public comment period, we have several regulatory action items on the agenda. The first will be fast track amendments for the regulation for licensure of nursing facilities. Rebecca Allen from the Office of Licensure and Certification will present those. Following that, Ms. Allen will also present final amendments to the regulations for licensure of hospitals. The next item will be proposed amendments to our Virginia newborn screening regulations. Jennifer McDonald with our Office of Family Health Services will present that item. Our final action item for the day will be updates to the State Emergency Medical Services Plan. Gary Brown, Director of our Office of Emergency Medical Services, will present that to you. I will then provide an update on legislation that was enacted during the 2020 General Assembly session. And Stephanie Gilliam, who's our Deputy Director for Budget, will provide you with a budget update on the agency. We'll then have other business, and then we're scheduled to adjourn. Madam Chair, if there are no questions, that's the agenda.
Are there any questions for Mr. Hilbert? All right, I do want to, Alex, we accidentally left Stacy Swartz off the roll call this morning. She is here. And with that, in order to get our discussion of minutes moving, might I have a motion to approve the minutes?
This is Wendy Klein.
So moved.
Okay, so I'm going to take, we're a little out of sync. I'm going to take Wendy as the motion and Linda as the second. Is that all right with everyone? All right,
Yes.
so I have a motion from Wendy Klein, a second from Linda Hines. Hearing none, and I think I see none. Alex, can you call the roll, please?
Yes. Mr. Kreitzer?
Yes.
Mr. East?
Yes.
Mr. Edmondson? Mr. Edmondson?
That was a yes.
Okay. Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison? Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Aye.
Thank you. Dr. Purist?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple?
Yes.
Thank you. And then just in case, Ms. Harrison?
Yes.
Thank you. Madam Chair, the vote was 15 ayes.
All right. 15 ayes, 0 nays. The minutes are approved. Just to remind the members that we are getting a fair amount of background noise. If you've got stuff going on around you, you may want to put yourself on mute unless you're speaking so that we're not picking up all your background noise. And we will move on then. The next item on our agenda is the commissioner's report, which will be displayed on the screen. Good morning, Dr. Oliver. Welcome. And on behalf of all of us, thank you for your very hard work these last couple of months.
Good morning, Madam Chair, members of the board. Thank you for that. This is definitely a team sport. There's no way that I will take credit for all the fine work that this department is doing. We have a lot of dedicated people in the 35 health districts who are working 24/7 to respond to the COVID-19 pandemic, and they've been doing an outstanding job. So I want to thank you for giving us that accolade, because I think that all of those public health practitioners definitely deserve our support and thanks. As Joe mentioned, this report is going to focus on COVID-19. If you'll go to the next slide, is an overview of what I'll be talking about. I'll do some situation setting, talk about the current status of the pandemic in Virginia, talk about our testing strategies and what we've been able to accomplish in that score, talk about contact tracing, deal with the outbreaks in the long-term care facilities and some other congregate settings, and give you an update on how the funding for all of these initiatives have, what that looks like. Next slide, please. So situation setting, I think that before jumping into the sort of timeline of COVID-19, I think it's important for us to recognize that one of the major things that we've found out in the course of this pandemic is that it doesn't affect all communities equally. The African American community, Latinx community, Asian American communities, and other peoples of color, as well as poor people in general, have been adversely impacted by this. This is something that's a reflection of the social inequities that exist in our society, and those social inequities we know have shown themselves to be there in terms of the health inequities that these communities have faced all along. And the pandemic has underscored that and shown that to be the case with COVID-19 as well. I think it's important for us to recognize not only this impact of the pandemic, but to recognize that the social inequities that these communities face, one of them happens to be the mass incarceration of people of color in the United States, as well as the repeated acts of brutality against that community. And today, George Floyd's funeral will be taking place at around 2 o'clock. And I want to let you know that that is part of the situation in which we're in, where there's communities that are being hard hit by this disease and continue to face police violence and other acts of discrimination. So we'll go to the next slide there. Hard to believe, it was just 5 months ago when we found out about COVID-19. At that time, and at the end of December, there was a cluster of 44 cases of pneumonia in Wuhan, in China. And the world took note of it. This was a novel pneumonia, and some people began to worry that it could, in fact, represent a disease that could spread pretty widely and become perhaps a pandemic. The Chinese worked diligently on this and isolated the novel coronavirus, got its genomic structure identified, and let the world know about that genome. The first exposed case outside of China was just a couple weeks after the 44 cases in Wuhan. Between the beginning of January, when the Chinese published the genomic structure of the novel coronavirus, the CDC was able to use that information to develop a molecular test to test for COVID-19. And then using that test, we were able to diagnose the first case of COVID-19 in January 21st. A couple weeks later, there was the restriction on travel from outside the U.S. into this country. Dulles was one of the 11 sites that were the points of entry, and we began to do contact tracing for travelers coming from China and elsewhere who might be positive for COVID-19. Next slide. So we began planning for this very early on. We set up our own incident command structure within the Virginia Department of Health in mid-January. We had daily meetings. We coordinated with our various partners at different levels of government and across many different other sectors in the healthcare systems and elsewhere. We were putting out situation reports several times a week. We were developing incident action plans on how we wanted to respond to this possibility of COVID-19 rearing its head in Virginia. We had weekly meetings with our local health districts, and we were on calls at both the local, state, and federal level with CDC and others, talking about what was going on in the world and what was happening, particularly on the West Coast at that time in Washington State. As you know, we do very extensive planning around emergency preparedness. We were able to go back and look at many of these plans. We pulled out the plans that we wrote around dealing with pandemic flu. We looked at what we had done around H1N1. We had actually an exercise in May of last year where we, ironically, the exercise was one in which a pandemic flu started in China and spread to the United States. And it was much worse than what COVID-19 was. And we went through all the processes of figuring out how we would respond to that. And we also did a number of local tabletop exercises planning for how we would respond. Next slide. As we were looking at and following the travelers coming through Dulles, we were also, as part of our plan, thinking about what we would do and what the potential triggers would be for taking more aggressive action to deal with COVID-19 in Virginia. And we were looking for community spread. We wanted to make sure that we were capable of doing the isolation and quarantining that would be required. And we're looking at how we would message all of this. We decided that the triggers for taking this to the next level would be as soon as we got our first confirmed case in Virginia, when the WHO, the World Health Organization, would declare COVID-19 a pandemic, which hadn't happened through February into early March, and whether or not there was any significant community spread in anywhere in the continental U.S. And all of those things happened early in March. The first confirmed case of COVID-19 in Virginia was March 7th. The WHO declared COVID-19 a pandemic, and there was clearly community spread in Washington state. Next slide. So as a result, the governor declared on March 13th a state of public health emergency. We broadened our incident command structure from a incident command structure within VDH to a unified command structure. Unified command structure is one in which it's multiple agencies and not only cross-agency but cross-sector. It involves partners in the healthcare industry and business and commerce and communications and so on. At the top of the slide there, you'll see the command structure for the unified command. We have big operations branch, a logistics branch, a planning branch, finance branch, a branch for dealing with recovery. And within each of those branches, multiple work groups working on various aspects of those issues. They report up through the chiefs of those branches, and those branch chiefs report to a unified command leadership group where all of the various agencies are represented. That unified command group reports to the secretaries of the governor. Also reporting to the unified command leadership group are a number of cross-cutting general command functions around legislation and policy. For example, we had one that was looking at, that's where we have our Joint Information Center, which is the where we do our media work and communications work. And I think very importantly for this effort, we developed a health equity work group at that level. This is something that I think is particularly innovative for emergency management. It's not something that I've seen done before in any of our emergency responses here in Virginia, and it's pretty unique nationally. This health equity work group, being at that general command level, could and does take a look at what we do in all of those other areas of operations, logistics, planning, finance, and so on, the communications efforts and other things that the Unified Command is doing, and helps those work groups and branches to look at how their work is being done in such a way that it really addresses issues of equity, diversity, and inclusion in all of those things. And that's been quite a help to our effort. Next slide. So I'm going to go on from there to discuss the actual current status of COVID-19 in Virginia. So we'll go to the next slide. This is the epidemic curve for confirmed cases by symptom onset here in Virginia. It's from a couple of days ago, so this is June 1st, I believe. So it's a little bit dated, but is adequate for our discussion today. The confirmed cases are presented by the date close to the onset of illness. You should know that BDH generally receives data on cases several days after the person has become sick. So this means that the most recent dates on this kind of curve will become complete over time. So you'll see the gray shaded areas. There are areas that we know there is still data that has to come in and complete that. And but that being said, this is the most accurate representation from the point of view of the disease timing and the course of the disease in the state. As you see, cases have continued to increase. There may be some slowdown in the rate of increase, but they're definitely still increasing. Next slide. This slide depicts the number of patients hospitalized who have positive COVID-19 tests or have tests pending for COVID-19. The light blue on the bottom are the COVID-19 patients who are on ventilators in the ICU. The next bar up from that in the slightly darker blue is COVID-19 patients who are in the ICU but not on vents. And then the dark blue are the total hospitalized patients who have COVID-19. The yellow or orange, depending on, I don't know how it's projecting for you, line is the 7-day moving average. And you can see that that's been flat to possibly in more recent days slightly decreasing across the state. Next slide. This slide is on the testing and percent positivity rate. So what you see here are the number of positive tests, and the darker blue is the number of people tested. So it's the total number of tests, or total number of people tested. And the line is the 7-day moving average of the percent positivity, so the proportion of those tests that are positive. World Health Organization has stated that a percent positivity testing rate of 10% or lower indicates that you're testing broadly enough to adequately, to say that you're having an adequate amount of testing done, that you're testing enough people to be able to stay on top of things from a containment point of view. This is not a test. This is not a way to ascertain the prevalence of the disease in any given area. Next slide, please. So I'll stop here. Is there any questions so far?
Are there
Yes,
any questions? Just your name before you ask your question, if you don't mind.
Yeah, this is Anna Jen. Doug Oliver. I have a question. When you look at our hospitalization rate, the cases almost still stay the same. I haven't seen a significant decrease. But when you look at the percentage of positive cases, has dropped almost 2 weeks. So I was wondering why, the hospitalization rate doesn't mirror, the positive cases identified. I was wondering what caused it.
Alex or Mylan, can you go back to that slide? I think it's one more. Yeah, there you go. So you're correct. If you look at the COVID-19 cases that are in the ICU, so the light blue and medium blue, that's been relatively flat for the entire. There was some increase in cases most recently as we moved into phase 1. There all that we reduced the restrictions around elective surgeries and other procedures in hospital settings. The hospitals, as they were taking in these new patients, have, as a general rule, been testing everybody who comes in for COVID-19. And there may be a situation where you have someone who comes in for, say, hip surgery, gets tested for COVID-19. They might be positive and not all that sick, for example, from COVID-19, put on a quarantine or isolation rather until and then come back for their hip surgery. While they're in the hospital and hospitalized or something like that, they will show up as a positive COVID-19 patient, and it's a reflection of the increased number of people who've been hospitalized, not necessarily because of COVID-19, but have a positive COVID-19 test. Did that explain that for you?
Yeah, they can't explain, but when I look at the trend for the total hospitalization patients, and also, the deep blue, light blue, and the middle light blue and the bright light are almost as, the same trend. I haven't, so I understand that your rationale that, but I don't think that's fully explained. The hospitalization, trend will stay flat. And then I was wondering some about, the death rate, and also sometimes it goes up and down, and looks like even about last week, the death rate still increased. So I was wanting to put all those pieces together, how to explain, the situations and then of the, the pandemic, and help us to guide how we can move forward. And so could you put that, the death rate, internal hospitalization into content, or any reason that you can, wisdom that you can share with us?
Okay, I see that Dr. Jabari has raised his hand, and he might have more to add to this. So he was in charge and still is in charge of the healthcare coordination work group. And the Unified Command can talk about this.
Thank you, Dr. Oliver. So a couple small points to be made. The ICU capacity is a lot smaller, as you know, than the entire surge. So had we looked at just the light blue, you actually would notice that also has had a gradual decline over the last several weeks. A couple points to be made. So we have had a gradual decline. From a clinical perspective, I think it's also been acknowledged that once we put patients on ventilators, they don't seem to fare quite as well. So we're being a little bit more aggressive in treating the patients prior to committing them to a vent. So we're seeing a downward trend. At the end of the day, we have a lot of vulnerable individuals, folks with chronic conditions, elderly, those that are high risk of COVID complications. And whether they are in nursing homes or other areas that have already been hard hit, we're going to have those individuals continuing to present, and realize that sometimes these patients are in the hospital for more than just a few days, a couple of weeks. So we may see the ICU trend lag a little bit behind some of our other indicators. So these people that you're seeing in the ICU at the end of May may have actually been hospitalized or gotten ill, at least at the beginning of the month, stayed home, didn't get better, it got worse, became hospitalized. So I would say it's a little bit of a lagging indicator. But two explanations is one, clinically they stay in the ICU a little longer. Two, just on this graph, had we shown you just the ICU numbers, you'd be better able to appreciate that slight downward trend in the light blue as well. I'll defer to Dr. Oliver and the state up east to kind of, or Dr. Falana
That
to talk more
doesn't
about
make
that.
sense. That doesn't make sense. I thought about that too, and I think I have the same ideas what you just presented on lack on all for the some of patients and moving into the get to the hospitalization and those have a clinical use. But how about those the patient from the long-term care facilities? Seems like that hit hard, very hard of it, and contribute by almost over 50% of the mortality rate. For all of the death in Virginia. And so have you seen more patients from the long-term care patients into the hospitalizations and also the death that, can you make some comments on that?
Sure, I wouldn't be, I guess I would just share that yes, we certainly appreciate that the greatest percentage of outbreaks have occurred in those congregate settings and long-term care facilities. I don't have the specific admission rates of where the patients are coming from, so I'll defer to Dr. Oliver on that particular issue. I think your question initially was, we're seeing a decrease in positivity rate and what's going on. And I guess I would just share, and we can provide some additional, more specific updates that graph. It is showing a decrease in the percentage of ICU hospitalized and the absolute number as well. So if we were to do percent hospitalized, and if we're able to look at the absolute counts of the light blue, we see that trending. But we can work with the VHHA to get more specific data. I don't know if Dr. Oliver or others would want to speak to the specific admission rates from long-term care facilities or nursing homes.
Right. Thank you, Dr. Jabari. Dr. Jabari, as you all may know, is the chief deputy at EDH. We don't have that breakdown, Dr. Jang, on who the specific hospitalization rates are, but it's something that we could ask our partners at the HHA about and see if we can get better data. I'll be spending quite a bunch of time later on in this presentation talking about the long-term care facility. So I'll hold off on that until we get to that point.
Dr. Oliver, I'm sorry. Dr. Oliver, I think Ms. Whipple had a question as well. Mary Margaret?
Yes, you mentioned that last May you had a exercise that involved a scenario of pandemic flu. I'm wondering what that exercise showed about the availability of PPE and if steps were taken after that. It seemed that we had quite a shortage.
The exercises on pandemic flu and pandemic flu, we didn't have the same sort of needs around the PPE. So that didn't turn out to be one of our major issues. And for the pandemic flu, we had a vaccine. So one of the major things we were dealing with was how to set up distribution supply chains and dispensing sites so that we could vaccinate, 6 or so million people, which turns out to be pretty challenging. So that was our major issue there. We can talk later about the PPE issue here with COVID-19. That did turn out to be a major problem, as you point out.
Thank you.
Okay, I think you can go ahead, Dr. Oliver.
Thank you. So let's dive into testing. Next slide. So our current situation is that our testing capacities have steadily increase. Initially, we had very few tests available. We were sending tests down to Atlanta to get verified. We now have a situation that with the state lab in partnership with UVA, VCU Health, VT, Virginia Tech Fralin Institute, and Fairfax Lab, we can do close to 1,500 tests a day. Through the Unified Command, we've contracted with 4 commercial labs that can do an additional 35,000 tests for us this past month, and will be working with us throughout June as well. Hospitals have been ramping up over this same period of time. We now have 12 hospital systems with a capacity for about 4,000 tests a day. And the commercial labs have been really ramping up as well. More than half of the testing in the state is being done through these commercial labs, and there's approximately 20 of them that are on board right now. Users of commercial labs are the hospitals, urgent care centers, community-based providers, pharmacies, private businesses will go to these labs as well. Next slide. VDH has leveraged numerous data points to identify 100 facilities that would benefit from having a point prevalence survey. This is a test that is conducted on all individuals in a congregate setting or facility, and it's at a specific point in time. And the idea is to identify everyone who is both infected and non-infected. And we've been using these point prevalence surveys, particularly at long-term care facilities and state correctional facilities. We've been working with the Virginia Department of Emergency Management and the Virginia National Guard to plan these PPS testing events at various sites. And we've also conducted them at some other settings. The meat and poultry processing plants, which in many ways is a congregate setting, given how closely densely packed those workers are, homeless shelters and other settings like that. We've been collaborating with our local district staff to reach out to and identify long-term care facilities, both skilled nursing facilities and assisted living facilities that might benefit from these, and then working with them to get their agreement for these tests to be done. Next slide. So this is from a few days ago. I believe we have over 200 testing sites available. This is on our website. People who go to our website can find this. People who use our symptom checker, COVID check, which they can access from our website and utilize there. If they get to the point where the symptom checker is advising that they get tested, they get referred to one of these sites. We maintain this page and update it every day. About 40% of these testing sites are urgent care sites, about 20% are hospitals, another 10% or so are pharmacies, another 10% are health departments, and then there's a mix of federally qualified community health centers and free clinics. About 20% or so of these sites are in that category. The pharmacies are increasing. CVS just got the approval to get funded for this through HHS, which means that CVS can provide testing for people with private insurance, and for those who are uninsured, they can get them the testing through this HHS portal. They put up 39 sites where they're going to do this and may be expanding. So that's really important expansion of testing accessibility in the Commonwealth. Next slide. One of the things that we're doing across the state is our local health districts have been partnering with others in their health districts, healthcare systems, free clinics, community health centers, and others to do testing events. And we've been trying to focus on really vulnerable communities, Black and brown communities, the meat processing plants in the communities surrounding them, and other areas like that. And this is just a representation of some of those events that have taken place in the last several weeks. Next slide. Madam Chair, perhaps I should see whether or not there's any questions on the testing before I go on to this section.
Okay, I don't have any hands up right now, but is there anyone who has questions so far about testing?
Yes.
Okay, let's, so Jim, I think that was you first, and then we'll see who, the next person can put a hand up.
I've got a number of questions relating to testing and both what's happened so far and what might happen going forward. The press reported, Dr. Oliver, that for a number of weeks, Virginia was reporting tests that overlapped both the diagnostic tests and the antibody tests. And it was apparently out of whack with what many other states were doing. I guess the one question is, how did that happen? Did it have any effect on the course of action that VDH was proposing, and have those has that overlap been corrected? So in the test reports that have happened in the past.
So the VDH's goal for providing the number of testing encounters is to be able to monitor our capacity of the healthcare system to actually perform testing. It's true that in the beginning we were counting all tests that were being done. Initially, there were only PCR tests that were even available. And the issue of including antibody tests or the blood tests, the serology tests, in that count was not a big issue because there was literally no such testing being done. That started to pick up some in April, and as it became a significant amount, we separated them out. The combination of the serology tests with the PCR tests had no impact on all the other methods that we were following. We separated out the serology tests from the PCR tests. It had no significant impact on measures like the hospitalizations or the percent test positivity or other things that we were looking at. So there was no difference in the trend when looking at all tests versus PCR tests only.
Okay. There is an incredible array of tests that have been where the agencies developing the tests have sent applications to the FDA for approval. Apparently, many of those are fairly quickly disqualified, at least as reported by the press, but they're still just scores, I guess, of such tests. Some of them require many days to get a result. I guess some of them are a bit faster. Are the tests that all of these testing sites in Virginia using of a similar reliability, similar time for reporting results. How is VDH and all of these testing facilities evaluating the quality of the tests and the reliability of results?
To get the most up-to-date sort of information on the testing, and as you said, there's an array of tests available, I would suggest that folks go to the VDH website. When you go there, there's a hyperlink for COVID-19 testing, and it will lead you to a web page where you can get information about all the various tests. The sites that we have listed are all sites that are doing the molecular testing. They're doing the PCR testing. The PCR tests are sensitive and very accurate. The turnaround time on those tests has gotten much better over the last few months, and even so at our state level, the turnaround time is 24 to 48 hours. Good. Most of the commercial labs are now also around 48 hours or so. So you can get the results back quickly on those. The antibody tests are the ones that have the most variability in their quality, and only a handful of them actually have FDA approval, and they shouldn't be used in any case.
Jim, are you?
One more question, just about the unfortunate history of the CDC apparently developed a test that they were encouraging everybody to use, and it was bungled, to say the least. They declined to use the recommended test that the WHO had developed. Give us a little background about that. I read something recently where somebody said it'll go down in the annals of the CDC as its worst failing.
Well, okay. I think of other things like the Tuskegee that was pretty bad. Might be a little bit worse. Anyway, the CDC's test, when you're testing for the virus that causes COVID-19, that's SARS-CoV-2 virus, when you do the assay test, they call it, you need a negative control. So you test that negative control, and your test should always say that that's negative. The reagent that was used for that assay worked at some state labs, but didn't work at other state labs. And that was why the CDC had to pull that back for a period of time, because they had to get a new reagent that would work better. And so there was a long delay there, as you know, before all of the state labs were able to use the CDC test.
Yes.
That's what happened. I can't speak to whether or not they should have used other testing that was being done elsewhere around the world. I don't know enough about that, but in the after-action review of this, I think we will all be able to look back and figure out where we had missteps and could have done things better.
Okay, thanks.
Thank you, Jim. Benita is next.
Hi, Dr. Oliver. I wanted to ask, given dental care workers are at the top of the list for risk, of disease or acquiring disease. And because we are working in the mouth, without the patient having a mask on, and we don't know how much disease transmission can occur via aerosols, but it is a risk. And so my question is, it would be ideal for us to be able to test patients who are going to be having a procedure that would produce an aerosol. When do you envision that a patient who has no symptoms can go and have a test prior to their dental appointment? Or is that available now?
I hesitate to say that there's enough testing resources available now that every single person can go and get tested. Now, although you're not really asking about that, you're not suggesting that we just go out and test the general public. You're talking about a particular situation, which is something for a dental procedure. Even at that limited scale, I wonder, I don't have a good answer for you on that. You would want to have a more rapid test, and the PCR tests at best are 24 hours that would require, someone coming in a two-step sort of way and getting tested that way. Would also raise issues of how you would pay for it. For example, not all patients coming to see their dentist would be in a situation to pay for that. Either their insurance might not cover it, or they'd have to pay for it out of pocket. So I'd be worried about sort of equity issues there, which then puts all of the risk, obviously, on the dental, either the dentist or the hygienist, who, as you point out, are exposed to aerosols. And I think aerosols are particularly high risk for being exposed. So there may be ways to do some, I heard from folks in ADA, for example, there's some guidelines that came down there about ways in which you could reduce the production of aerosols with certain procedures. And then clearly we need to do everything we can to get dentists and dental hygienists the PPE that they need so that they can protect themselves. I think that's where we should focus at this point. Thankfully, there's been efforts around that. We've been reaching out to the Dental Association here in Virginia and trying to work with local providers and finding ways to get the people you represent the PPE that they need.
Well, yeah, we would like that. That would help reduce our risk tremendously. And we have been, we have always treated patients as if they have a communicable disease. That's why we use universal precautions. So we are doing that. But given this, high degree of transmission capability and the aerosol issue, it just would be nice to have one extra sort of safeguard, as it were. I mean, I know that testing isn't 100%, and we can't count on that 100%. So we are taking extra precautions above and beyond what we have been doing in the past. But I think for a bigger procedure, similar to someone going to an outpatient facility, they're going to be tested. They'll go to a Better Med or St. Mary's Hospital or something like that. And I'm not even advocating for dentists to test in their office. It'd be just great to say, okay, here are the places you can go. We're going to be doing this big procedure. We'd like for you to get tested. Do you feel like there's that capability?
I don't know any of my other folks from VDH can speak to that, but I believe that the testing resources, while they have increased, they haven't gotten, they're still more limited than we would like, okay? I think it's, that being said, I think it's a completely reasonable thing for a dental practice to ask if you're getting ready to do some major oral surgery or, you know, it's something else that's going to require you, that will put you at increased risk of if the patient was COVID-19 positive. I think it's reasonable to ask in the same way the hospitals do when someone's coming in for an out, you know, procedure. They're testing folks. I think it's reasonable to do that. Now, the hospitals have the advantage that many of them have their own labs, so they can run the test when they come in. The disadvantage for you all in the outpatient setting is that you have to put that burden on the patient.
Yeah, yeah.
Okay, we have,
Yeah.
oh, go ahead, Benita.
Thank you.
I'm sorry.
No, thank you. Yeah.
Dr. Jabari has raised his hand and says he has something he'd like to add to this.
Thank you, Dr. Oliver. I was just going to share a couple principles I think we may touch on later as well. It all becomes interrelated. A major hindrance of the testing had been getting the providers in the community appropriate PPE. So we've made some significant strides over the last several weeks, as all of you saw on the slide. We did a really good job of getting the PPE to the acute care facilities, then some focused efforts on long-term care. And now what we're hearing, both the dental health providers and others in the community, including primary care and other folks that will need to see their patients and see these folks to help us really get us to where we need to be for testing. One of the hindrances has been a lack of PPE. So in order to get the testing up, we have to do multiple things. And that's another consideration to be had. I think we've talked a little bit about this in testing. Again, everybody's important. Everybody needs a test, and we should get them that test. But our focus has traditionally been on assisting the communities and individuals who are symptomatic. So a lot of our testing has focused on, and when you see those advertisements around Richmond or other places, the ones that are community led by the health department usually ask for those individuals who are symptomatic to come forth. So I think our supply capability, both on the testing side and the PPE, is increasing. So we're beginning to do much more of the community-wide testing and really getting to the asymptomatic. I think just as a general rule, and again, this is not necessarily the way it's going to be, but the way we've had to proceed over the last several weeks is, again, to prioritize public health investigations, prioritize testing for those who've been ill, and for providers that want to help us test, whether it's to resume an elective procedure, whether it's to do oral health, is really the burden has been on the providers on getting that started, and we're continuing to work with them to facilitate that. While I'm on the line, I'll just share that to kind of assist with that general community effort, so, and to help individuals kind of navigate towards where the testing strategies, where testing sites may be. We have on our website an up-to-date listing of where individuals can go for testing, and we've also launched the other service you may have heard about, Virginia Symptom Checker, or the BOUI, B-O-U-I health app that allows individuals who believe they may be symptomatic to go on, register simply where they are in terms of the zip code. They don't have to provide any specific patient information. And if testing is appropriate, they would be guided to the 3 closest testing sites. So I guess I say all that to, again, re-summarize. Our testing has focused on those who are symptomatic and those who've been ill. We're going to continue to provide assistance to community providers, oral health, primary care physicians to get the testing. as well as the necessary PPE to do so. And we're encouraging the general population to identify whether testing is appropriate for them through the use of a web-based app. So we still have a ways to go, but we are making significant strides towards that effort.
Thank you. That's great.
Okay, I think we still have a few other questions here. Ms. Whipple, did you have your hand up here?
No, I don't know how to lower my hand.
Okay, we'll work on that. How about Dr. Jang? Do you have your hand up still?
Yes, I still have a question. Dr. Jeffers, provide very good information about the testing. It's good news, really, and it's no doubt. Yeah, the testing capacity had increased significantly comparing to April. So university or schools, several of them are planning to reopen in the fall. And so we are gradually entering the phase 2 reopening. And I do know that we do have now testing for the now. And I wonder whether still the same in the fall. So, and my second question is that it is possible that the COVID pandemic will occur at the same time during the flu season. So that will complicate our capacity, the testing protocol strategies, and also the availability. Those are the two questions that I have. So I live a little bit ahead. So go ahead.
Okay, thank you for that, Dr. Jang. Actually, it's a nice segue into this next section because our whole plan around containment addresses both what's you asked regarding the schools and also what we think we might be dealing with in the fall. So if you don't mind, I'll hold off on answering that until I get into this section and see if there's anything else on testing before we move on.
Thank you.
All right. Was there anything else? Did anyone else wish to speak or ask a question? I'm sorry.
Yeah, Faye, this is Tommy.
Okay.
First, Dr. Oliver, let me thank you and the department for everything that you have done for the long-term care industry. I'll try to just limit several of my questions just to the testing. Obviously, as you know, with what CMS has recommended for reopening nursing homes and the number of testings they're talking about, which doesn't seem realistic to do tests every week of all of our residents and test the employees every week. For most of you, if you've had the test, know that the nasal swab test is very, very uncomfortable. I think I still have my left eye slanted to the left from the test. But I guess my question, and I was on a meeting yesterday with Richard Wenzel from VCU, and some of you probably know him. He was speaking of a test, a saliva test. Do you have any thoughts on that? Is that something that you feel like that could be something that we might be seeing coming soon, and the accuracy of that?
Yeah, I'm good. Yeah, I'm off mute. There are a couple different tests which I'm hopeful will get used more in sort of broad-based community testing and in sites like long-term care facilities. One is the saliva test. They're working on that. The test parameters on that are not that bad. They're pretty comparable to the nasal swab. Or the one you're talking about is a nasal pharyngeal swab. So it goes through the nose all the way to the back of the throat. There's a different nasal test that's just literally a nasal swab. So it's like putting on a Q-tip just in your nares. And several of those are coming on board as well. Those can be self-administered. So someone, which will also help on the PPE front, because a person who's, because the way the nasal pharyngeal swab is done, you have to be in them, have a N95 respirator, face shield, a bunch of other things. And if someone else is doing a nasal swab, all you need is gloves and a gown and a mask. So anyway, those things are coming. They're not quite ready yet. I would agree with you that the recommendations coming down from CMS are going to be particularly onerous on the long-term care facilities, and we'll have to work with you on that one, see how we can help you meet those demands.
Okay, thank you. Second question is, we have done several PPS tests in a lot of our facilities and across the state. When we did one of the labs was the Virginia Tech lab when it initially opened, and there were a lot of discussions about the viral load. That seemed to really lose its punch. We didn't get a whole lot more about that, but I guess, what is your thought? Does that something that seemed that is beneficial? Does that just tell you kind of where you are in the process of the virus? Just curious your thoughts on that.
I don't really know much about that as a test parameter. You need a certain amount of the virus in your system to really be in a position where you can actually pick it up in the PCR test, and that may have been what they were talking about there. So I guess the bottom line is I don't really think I can answer that. The other thing you should know is I'm being told here by Dr. Tony that the state lab is working with VCU and IDA to evaluate saliva as a possible specimen type. So in answer to your previous question, there's ongoing work that's happening right here in Virginia to try to improve the testing capabilities using the saliva test, which would be a big help. But anyway, on viral load, I don't think we're not looking at that as a way of testing for the presence or not of COVID-19. We're going to use the PCR test. It might have something to do with infectivity, whether or not someone is able to spread the disease more readily to others.
Okay. Thank you. I will tell you, we had one facility that we had 33 residents that tested positive. 32 of those 33 were asymptomatic.
Wow.
Which was pretty amazing. So,
yeah. Wow.
But anyways, thank you so much.
You're welcome.
Thank you, Tommy. I believe, Dr. Oliver, that is all, those are all the questions for this section. If you want to move on to contact tracing.
Okay, thank you. Next slide, please. The contact tracing is part of a containment strategy. And the strategy here is that we want to box in COVID-19, contain the spread of the disease. This is particularly important as we open up. Dr. Jiang mentioned, we're moving through the various phases. We are opening up more now. Tomorrow we move into phase 2. We're looking at the K through 12 and the institutes of higher education opening up more over the summer and into the fall. As we open up, the incidence of this disease will increase. What has kept the incidence down has been our social distancing and physical distancing from one another. And as we open up and interact more, we can expect the cases to increase. And what we need to do then is develop a strategy that recognizes that fact and then contains that spread. It requires testing widely and identifying cases early. And then those cases can be isolated so that they don't spread it to anyone else. We need to find out what everyone who that case has been in contact with, and ask those people who've been in contact with that case to isolate them, to quarantine themselves for 14 days. And in that way, we box in the disease. Next slide. It's a busy slide, but it sort of outlines the way in which we go about doing the contact tracing. So a confirmed case there on the upper left, we ask about their contacts. Among those contacts, those who are symptomatic and get tested and are confirmed as cases, and we ask them about their contacts and repeat that cycle. For those who are asymptomatic, we ask them to self-quarantine, watch their symptoms, and if they become symptomatic, then we confirm them as a case, ask about their contacts, and the cycle goes on. Next slide, please. Contact tracing is primarily done by our health departments. This is something that our health departments have always done. We do contact tracing on sexually transmitted infections, on tuberculosis. We do it on emerging infectious diseases like Ebola, Zika, and obviously now COVID-19. As I said, we have case investigators who talk to each person who's become COVID-19 positive, find out about their onset date, evaluate what their infectious period is, and then identify the contact and exposure sites that case reveals. Then the contact, we reach out to and give education on COVID-19, symptom assessment, give them instructions around self-quarantine, and then work with them to provide the wraparound services that they need, since we want them to stay in quarantine, and obviously that they need food and medications and other things. We want to ensure that they get that so that they're able to stay in quarantine. Next slide. In order to deal with the increased number of cases that we expect, we know that we need to ramp up our contact and tracing and containment workforce. Harvard University came out with a study that showed that you need somewhere between 15 to 30 contact tracers per 100,000 population to adequately identify every case early, identify all of their contacts, and both isolate and quarantine as necessary. We are shooting to, by the end of June, hire enough people so that we hit that minimum goal of 15 contact tracers per 100,000. This is a monumental lift for us. We have currently about 400, well, last week we had 472 FTEs devoted to contact tracing. In the last several days, we've hired another 138. We plan on hiring 200 additional case investigators and 1,000 contact tracers to augment our workforce. This, as I said, is a big lift for us. It's increasing our workforce by 25% in a month or two, a little over a month. So you can imagine the strain this has put on us, but we expect to meet this goal. We'll have regional support teams that will provide assistance with this for our districts. We've worked out some standardized workflows so that we can be sure that this is done with best practice and uniformly across all the districts in the Commonwealth. And we've integrated a number of applications to help streamline our efforts and improve the data management for this operation. Next slide. Part of what we're doing is with our contact management, data management systems will allow us to track a number of metrics. These are ones that we have looked at. These are process metrics, but important ones for us to follow. We want to make sure that we identify cases within 24 hours of the report of that case, that we reach out to all contacts of that case within 24 hours of the investigation, and that we then appropriately test, isolate, and or quarantine all contacts within 24 hours of the case investigation. Next slide. Okay. If you don't mind, for the sake of time, let me go on and talk about this before we take questions.
Okay.
Next slide, please. As Dr. Jang mentioned, the outbreaks and Mr. East mentioned as well, outbreaks in the long-term care facilities have been pretty devastating for the residents, for their families, for the staff, and represents a major part of the disease epidemiology here in Virginia and across the country. As of a few days ago, on June 1st, there was 7,935 outbreak cases. And as you can see, the majority of those outbreaks, of the 362 outbreaks, the majority of them were at long-term care facilities. Now, long-term care facilities include both the skilled nursing facilities and the assisted living facilities. The congregate settings, there are other like group homes and behavioral health settings. That's what's included there. And then you have the correctional facilities and a couple other places. Next slide.
Norm, I'm going to stop you just for 1/2 a second here. I'm getting some interruptions. And it does not appear to be coming from my internet. It appears to be coming from WebEx. Am I the only person who's getting that?
I'm not having a problem.
Okay, that's great. I'll keep up. I just wanted to make sure everybody was getting, I want to make sure everybody has access to what we're hearing. Okay.
Good.
Okay. Go ahead, Norm. Sorry.
No problem. And again, as long as everyone else is on mute, that also will help.
Okay.
Unless you're speaking. This slide, you'll see a breakdown of those outbreaks. As I said, it was 7,935, I think, cases in the outbreaks as of June 1st. And you'll see here that 4,900 of those are in long-term care facilities. So a huge proportion of the outbreak cases are there. The deaths in long-term care facilities were at 785 on June 1st, so that more than half of the deaths in the state come from long-term care facilities. So majority of cases in long-term care facilities have been at the skilled nursing homes. 14% of the cases occurring in nursing homes have resulted in death. That's a very high case fatality rate. 19% of the cases occurring in assisted living facilities have resulted in death. And 22% of the cases occurring in other long-term care facilities have resulted in death. And this is probably an underrepresentation, since these are stats that we calculate based on the cases that come into our electronic data, our electronic disease surveillance system. There are other deaths that don't necessarily get recorded there. Next slide, please. Just to give you some framework on state oversight of long-term care facilities, nursing homes and skilled nursing facilities are regulated by VDH. Most facilities are certified by CMS and receive payments from DMAS for Medicaid eligible residents. Assisted living facilities are regulated by the Department of Social Services. They're not certified by the federal government, and DMAS does not provide payments to assisted living facilities. And the assisted living facilities, as a result, are far less resourced than usually than the skilled nursing facilities, which is saying something, because I believe that, and Mr. East may agree with me on this, that nursing homes and skilled nursing facilities are also challenged by under-resourcing. Next slide. Recognizing that the disease in long-term care facilities was a major challenge that we needed to deal with, the governor established a long-term care facility task force in April 10th, I think it was. This task force convenes weekly. It's a very broad organization that involves all these partners that you see here and more. They've tried to develop a unified and whole of government response to the pandemic and its impact on the long-term care facilities. It's got more than 125 members in this task force that breaks itself down into a number of work groups, which we can see on the next slide, I think. And these work groups deal with a number of different aspects. If you can advance that slide. As you can see here, on different aspects of what needs to happen to improve our response to COVID-19 in long-term care facilities, and in particular doing a lot of work on testing, financing, staff, infection control, PPE, and then that work gets brought to the larger committee meeting, task force meeting rather, every week. Next slide. The Medical Reserve Corps, which in the course of this pandemic has grown a lot. Last time I looked at a figure, it was a little bit north of 17,000 volunteers. One of the things that the MRC has been able to do is to help address the staffing shortages in facilities that have outbreaks. And this has been a really important source of support for the long-term care facilities. We also are partnering with the Virginia Hospital and Healthcare Association. Hospitals have provided some assistance locally to the long-term care facilities, helping out on staffing, helping out on infection control, and other things. We continue to work on accessing personal protective equipment supplies for the long-term care facilities, which has been a big challenge, but has improved over over time. And we've also been helping them with the infection control technical assistance on that score. We've provided a playbook that supports efforts to request staffing support and get these testing supplies and PPE. There's a companion playbook that the local health departments use to help coordinate responses to the outbreaks in these facilities. I think we should go to the next slide. At the state level, there's been some other assistance that's been garnered to help the long-term care facilities. So the General Assembly increased the Medicaid payment by $20 per resident per day, which was helpful. We waived a number of state regulations, none that would dramatically affect care, but just paperwork kinds of things that the facilities had to do, that we wanted to reduce that burden so that it could spend more time focused on using that staffing for other things, infection control and such in particular. At the Unified Command level, we have utilized the Virginia National Guard to conduct a number of point prevalence surveys at long-term care facilities and also provide PPE training and fit testing. And like I said, we have this playbook that we developed. Next slide. We have, as you see here, a number of point prevalence surveys have been conducted, and you can see the breakdown here in the ones we've done so far. We've identified about 100 priority long-term care facilities where we want to conduct point prevalence surveys, and we're in the process of contacting those facilities, talking to them about the pros and cons of doing such a survey, and working with them to understand what they'll have to do as a result of those surveys. Going into the surveys, long-term care facilities are already challenged with having sustainable staffing, and coming out of such a survey, that challenge is often increased. Next slide. Outbreaks result in a large number of staff testing positive. When we do these PPSs, we find a lot of residents, as Mr. East mentioned, who may have been asymptomatic but positive. That's also the case with staff. And so you have a situation where it's hard to recruit, it's hard to retain staff, and then you lose staff who now have to be in isolation or quarantine. Next slide. Mr. East mentioned the CMS recommendations. So a couple weeks ago, CMS released guidance for reopening the nursing homes that includes recommendations that all residents be tested as a point prevalence study, and that staff be tested every week. This will be a big burden on the long-term care facilities. VDH is working with CMS and DMAS and other folks like the hospital systems and others to figure out strategies to support this testing of long-term care facility residents. So more to come on that. Next slide. This is a slide. It's depicting some work we did around the meat processing outbreak in 2 plants on the Eastern Shore. We also had outbreaks in meat processing plants in the Shenandoah Valley, did a lot of testing both in the plants and in the surrounding communities. We worked with plant management on physical distancing in the plant. Normally these workers would be shoulder to shoulder. They're separated more here. They have plexiglass dividers in between them. They're in PPE. So the plant management worked with us on that. They tested all the workers, and we got that situation under control, which is really important. Riverside Shore Memorial is a very small rural hospital there on the Eastern Shore and would have been completely overwhelmed had the outbreak not been contained in this way. Next slide. Probably skip this, but before we do, the one thing I do want to say here is that these workers are particularly vulnerable population. The majority of them are Black or African American. There's a large Haitian population that works in these plants, and then a significant number of Latinos who work in those plants. Between the 2 of them, you're talking to close to 70% or so of the workers. It was really important from an equity point of view that we get on top of this outbreak as well. Next, I think the next slide gets into the finances. Is that right? Yeah. So I only have
Do you want to stop
few
questions
slides.
there?
No, actually, I only have a few slides in this. I'll do that, and then we can just take whatever questions.
Okay.
So next slide. Federal funding that we've used for our COVID-19 response. There's several funds that are pretty narrow and specific in their purposes, like the Child Nutrition and the Ryan White funding that allowed us to do some things related to COVID-19, but it was really very specific. The CARE Act also provided some funds that were utilized by local health departments there in that last category. We'll go to the next slide, please. VDH has a number of pass-through funds that we utilize in this response. The Hospital Preparedness Program is an award that we use to work with the VHHA in supporting the healthcare coalitions and EMS and some other functions around the state. And then that coronavirus state hospital improvement program was aimed at helping critical access hospitals in rural areas who really were hard pressed to have funding. Next slide. And finally, we had some funding from through the CDC, the COVID-19 Public Health Crisis Response, $13.6 million, which has helped us a lot on our public health surveillance work. We've been able to use some of that funding to help expand laboratory capacity and work on the infection control and other mitigation things that we've done in long-term care facilities and elsewhere. And that's been also true with the epidemiology and laboratory capacity grants, the ELC grants. We've received to date about 14 million or so in ELC grants. We are currently, there's a funding opportunity for another 213 million, and that's why the total there is listed as 227 million. The 213 million is not real at this point. We are applying for that, and we will hopefully get it. We need it in order to help extend the funding for our contact tracing. Through the CARES Act, the stimulus fund. We have been approved for $58 million between now to December 30th, when the stimulus funding ends, for contact tracing and containment program that I talked about. But that's just to the end of the year. We believe that we will need to obviously continue that work into 2021. As Dr. Jang mentioned, we don't know yet, but it is possible that we could see a second wave of COVID-19 in the fall and winter, in which case we will obviously need a lot more flesh on the bone of our containment workforce, and we'll want to expand that and continue that work. And this ELC grant speaks to the need to expand that workforce. And Madam Chair, I believe that's my last slide.
Thank you, Dr. Oliver. We do have questions. If you want to go ahead and put your hand up, I will try to get to as much in order as I can. I think where we are now is that Dr. Kinzer is first, and following that, Jim Edmondson has something. So Dr. Kinzer, if you could go ahead.
Sure, thank you. So I appreciate all of the discussion about infection containment. I'm going to shift the discussion just a smidge. My research team mobilized this spring to conduct a study on the impact of COVID-19 on pregnant and postpartum women. We're conducting the data analyses now, but one of the key themes arising that won't be a surprise to many people is that while some women are saying that home is their safe zone, many feel that they are experiencing increasing levels of anxiety, depression, and stress, especially those women who are having to quarantine or isolate with partners with whom they do not feel safe. So has there been any consideration regarding additional mental health resources for pregnant and postpartum women in Virginia?
I don't know any specifics around that. I would agree with you that this is a major issue. The behavioral health needs of pregnant women and others are greatly increased, I think, in the course of this pandemic. There's also increased need to deal with issues of intimate partner violence, I believe, which has also been increased in the pandemic and the stay-at-home phase of things, where home is not a safe place. Staying at home increases that violence. But I don't know the specifics on that, Dr. Kinzer, I'm sorry. But we could certainly look into that and check with our partners at DBHDS and elsewhere.
That would be great, thanks. And we are actually in the process of creating some infographics to share with the health department in Virginia and also local clinicians and health systems, just to report our data, if that could be of service.
Thank you, Dr. Kinzer. Jim was, I believe Ms. Waddell is after that.
Hi, thanks. Norm, really appreciate your extensive report. I wanted to make some observations regarding an assisted living facility. I'm a member of the board of a nonprofit assisted living facility in McLean, Virginia, Northern Virginia, which has had some wonderful success so far in limiting the number of problems. As a board member, I've been aware of how important management of these facilities is. It has been re-emphasized during this period. We've had relatively few residents with problems. We did actually have the death of one staff member, which was shocking, but there were apparently some underlying conditions that affected that result as well. But one of the things that our manager was able to do very early on in the process was to apply for and get the federal funding for personnel costs. And our facility is very well funded, very well financed. We were able to avoid anything like a layoff or salary reductions or anything of the sort. And I would hope that Tommy and your members were able to do some of that in appropriate cases. It's turned out to be very, very meaningful. And we're going to continue to monitor, and we're close supervision of this situation is obviously critical.
All right. Catherine, did you have something? Catherine? All right. Well, if Catherine comes back in, we will we'll let her back in with her question. Did we have any other questions for Dr. Oliver?
Yes, I do. This is Anna Jen.
Hi, Anna. Go ahead.
All right. I did write an op-ed piece and published in the Virginia Pilot about contact tracing. And then after the article, several people contact me because regarding the privacy, because in the op-ed piece, I did express my support of using the software to track the cases because coronavirus is very contagious. It's difficult to contain it or box it just by manual methods. And so a lot of people raised the concerns about privacy. And so a lot of people call me up and ask me whether they know VDH have been planning for the contact tracing. And I was wondering whether VDH is planning to use any software or apps, which installed in the cell phone to assist contact tracing effort. That's my first question, and I still have another question. If
okay, let me deal with that one first. So we have a number of different applications that we're using to improve the efficiency of our contact tracing. A lot of contact tracing or containment work is the result of boots on the ground, talking to people, visiting them, interviewing them, and so on. There's a lot of calling. So we have call centers set up around the state to deal with that. The biggest piece of software we have is our contact database management system. It's called Sarah Alert. It is a very robust system that allows us to track how we're doing on those metrics that I mentioned earlier. Did we get in touch with the case immediately? Have we identified all the contacts and then reached out to them? Contacts who are positive, have we gotten them into isolation and quarantine? It tickles us to make sure that we stay on top of those sorts of things and other things, and it allows us to generate reports. Integrated into that contact tracing on a database management system is a proximity tracker that we have just signed a contract with Google and a software company called SpringML. This is a software that utilizes the Bluetooth mechanism that Google and Apple have in their system, so it does not use GPS or location identification or phone identification. So there's no personal identifier associated with this. What it allows us to do for people who opt into it, and that's the other thing, it's completely opt-in. if you opt into this and download the app, if you are in, we haven't yet finished setting up all these parameters, so I'm making this up right now. But let's say you're within 6 feet of someone who also has the app, right? You're in 6 feet of someone for longer than 15 minutes. And it turns out that person becomes COVID positive. They post, on using the app, identify that they're COVID positive, and then everyone they've been in contact with will get a notification that they may have been exposed to COVID-19, and then they can act on that, and they will be given instructions on how to act on that. In addition to this proximity tracker, we have a symptom checker called COVID Check. So if you go to our website, you can find a link to that application. It's actually a web-based tool. And this symptom checker will walk you through the steps of you're talking about what symptoms you have and whether or not they mean you are likely or not to have COVID-19. If depending on what your risk is, it'll give you suggestions about whether you should contact your provider, or if you don't have a provider, give you information of other resources that you could tap into for clinical care, and will also direct you to testing sites that are nearby. So we have a proximity tracker that's not quite online yet. We think that will be online by the end of June, middle of July. We have a symptom checker that is already up and running. We have a database management system that's up and running. And those are the technology enhancements we've instituted to aid our containment strategy.
Thanks so much.
Answers your question, Dr. Jung. And you said you had another?
Another is, I do know some universities are going to establish their tracking, contact tracing effort. And so because a lot of students are going to come back in the campus in the fall, and sometime probably start in August. So I was wondering what effort to integrate this contact tracing into the state effort you are talking about. And I do know some of universities work with the local department of health. So I just want to get to a much better sense of what's integrated effort about, contact tracing. That, have I made my question clear?
Yeah, you did. Yeah. So thank you for that. And actually, I think you sort of gave the answer to it as well. What's happening, local health departments are working very closely with those universities and colleges. So I know here in Charlottesville, where I am, the University of Virginia and the Thomas Jefferson Health District are working very closely together. The contact tracing and containment team at Thomas Jefferson is working with student health, and student health has a whole team set up for screening students, identifying students who have symptoms that may be concerning for COVID-19. They'll be testing them, and then if anyone's positive, they have their own network for doing contact tracing, but it's linked up with the health department, because obviously the students don't just stay on the campus, right? They're out and about in town. You need to be able to follow up on other aspects of their movement, sites they've been, and contacts they've had elsewhere in town. So yes, you're right. It requires the coordination of our contact tracing team with the universities and the colleges. Some colleges and universities obviously are better resourced than others. And I think in those situations, it's even more important that the local health department work with that institution of higher education to help them do the contact tracing that will be necessary when cases develop on their campuses.
Dr. Oliver?
Well, thank you.
Thank you.
I am. If I could ask my question.
Yes, Catherine, it's your turn.
Thank you. What I would like to ask is relating to PPE, and it's not for healthcare workers. I represent consumers, and I'd like to know access to masks. We're required to wear masks, and people are always asking me, where can we get something that we know is covering us well, not just a handkerchief or a scarf, but something when we go into a grocery store or any place for an amount of time. You know, you may be in there for 20 minutes or so.
I would invite anyone else on my team who knows more about this to chime in if they like. I know that these sorts of things are back ordered. For those of us who have access to Amazon and Amazon Prime and whatnot, you can order masks there, cloth masks. The cloth masks work very well. They're harder to breathe through than the sort of non-medical surgical kinds of masks that some of us have as well.
Excuse me, Dr. Oliver, but one of the things is, you know, we are required to wear masks. Therefore, I think there should be some sort of access. I have also mentioned this to the governor. There should be some way that people can access these that are they feel, you see somebody in one of these, that you know that you're protected and that they're protected.
I agree. We need to have access. I think the only access we have right now is to sort of the normal supply chains, like the retailers and both the brick and mortar retailers that have some of these materials from time to time, but especially the online ones, which is, for example, where I've gotten all my cloth masks from.
Well, as a member of the Board of Health, I would appreciate it if we could have an answer for our consumers and people that ask us about this, because they expect us to know some of this. And if anyone in the health department can find out where we could access these, or that the state could access these so that people can have the protection that they need when they go into these places. Thank you.
Okay. Thank you, Ms. Waddell.
Our next question is from Stacy Schwartz.
Dr. Oliver, I'm going to put my small business hat on for just a second. As you see some businesses that are reopening up here in Northern Virginia, no one wants to be that business that makes the news that says that they spread COVID to their entire community. So I just wanted to ask really quickly what steps on the state level that you all are doing to help, especially non-healthcare businesses, to reopen, to make sure that they keep their clients safe. I know my local health department has a great program that we can go through a training process and get like a good housekeeping seal of approval that, you know, we have gone through the training program so our customers can feel safe for us. But I wondered if you were doing something like that on a state level as well.
Dr. Forlano, did you rejoin us?
Can you hear me?
Yes, we can.
Oh, super. Great. I was having difficulty before. So I'm not sure that there's a state level program as is being referenced for small businesses, particularly the non-healthcare businesses. The Secretariat of Commerce and Trade is kind of the point of contact for the business community. We've been working incredibly closely with Commerce and Trade on the development of all the guidance, including participating on stakeholder calls and including their feedback in the guidance that's developed to the extent that that's appropriate and possible.
Did I see Dr. Jabari trying to participate or no?
Hi, I just wanted to finish the response for the masks, just to make one distinction. We are working very closely with the Virginia Department of Emergency Management. I referenced this earlier in terms of the priority groups focus on the hospitals, the long-term care. Certainly the general public is a major concern. And so I think to the clinicians who are out there know this already, the idea here is to prevent droplet transmission. We realize that it's possible for that virus to come around the mask in an aerosolized fashion. It's a very, very tiny particle that one could potentially breathe. But we're really thinking those kinds of things happen in the dental office or in the operating room or in other medical procedures that are really more invasive. So I think the important thing is, yes, there are different looking types of masks, and individuals may feel more comfortable in one versus the other. But the simple object here, and that's why handkerchiefs or other cloth masks work as well, is to simply provide a barrier from breathing in those droplets. So yes, there are different grades to masks. And in the healthcare setting, we're very specific as to who wears it at what point. For the general public, you know, anything really that prevents that droplet from, and it's more really to I guess, in the public setting should emphasize, it's more about the droplet from the individual who's already sick to prevent them from spreading it out into the grocery store or other areas. Any sort of a barrier helps. The other point in terms of what we say to concerned citizens is the Department of Health, we've really focused on the healthcare side, so getting the medical quality grade PPEs. What we have done with VDEM is have them work through the local county emergency management officials to provide protective gear for the community, for the residents, and individuals who are not involved in medical care. So the brief answer for where do we have citizens go is actually, if they're not healthcare providers and they're just concerned about their potential exposure in the community, is to go to the local county and emergency management official. And our VDEM partners are working with private companies to help facilitate the distribution of the non-medical grade masks as well. I actually have a meeting with them tomorrow. Happy to inquire more about that specifically. But when we look at the health department, we supply the local health departments who provide PPEs to the community providers. The Virginia Hospital and Healthcare Association provides a PPE to the hospitals, dialysis centers, and nursing homes. And to the general public, we work through the local county emergency management officials. So I just want to, again, bring that distinction of a medical mask versus just a barrier that helps prevent the spread, and the distinction between the health department role and the county emergency management role.
Faye?
Yes, ma'am.
May I comment on what he just said?
Sure. This is Ms. Waddell speaking.
While I understand what you're saying, an emergency management department, that all sounds good, and also that people can just put anything on, they don't always stay on. If it's not a real protective mask, they fall down while they're in the store. They're constantly trying to pull them up. And this, I'm led to believe that this is so contagious that we have been told to be very careful. And people are not, the general population needs help with finding this. This is now, I understand this also is a requirement that we wear a mask when we go in a place. And so I really think, and while I understand what you're saying about the Department of Health, as a member of the Board of Health, people do come to us because they expect us to have an answer as to where they can find something like that, a mask that's actually going to protect them and the people that they're going to be speaking to. Thank you.
Thank you. Next is Lisa Harrison. Alex, is Lisa unmuted? Alex, okay, gotcha. Ms. Harrison, your turn.
Okay. A question for you. This is not really on the masks, but more on testing. My husband has a law firm with about 120 employees, and he's trying to bring everybody back in, and he is having everyone be tested first before they come back in. But that's all great, and he'll send them to a Better Med or whatever, and everybody will do that, and the firm is going to pay for that. But that's great for a while, but then he would like to be able to get everybody tested like at least once a month. Every day is too much, but maybe once a month. But then the cost of the testing is not cheap, and is there any way that VDH can require Anthem, for example, or health insurance to cover the cost of multiple tests? Again, not every day, not overly excessive, but until we get past this point in the pandemic where we're coming back online and things can resurge so quickly, what good does it do to test everybody once, then bring them back in, and then you've lost control again? So any thoughts on that? And this is kind of more of an insurance question, really, but
Thank you.
Can anyone weigh in?
Sure. Thank you, Ms. Harrison. It's really a question about what is an appropriate sort of screening and containment strategy. As you sort of intimated in the question, testing just gives you an answer about one point in time. The day that they were tested, they were either positive or negative, right? Someone who's negative today could be positive 3 days from then. How often do you do the testing? What should be your strategy for screening and testing in those situations? And I would actually, if Dr. Furlano, who's our Deputy Commissioner for Population Health, when I showed you that unified command structure, there was underneath the operations branch, there was something called the COVID-19 branch, and they had all of these work groups. She's our chief of the COVID-19 operations and has been heading up our work around containment and community mitigation strategies, and has thought long and hard about this issue of what's the best way to, what's the best strategy to have for testing and screening. And so if she's still on, I'd ask her to address this question.
Hi, this is Laurie Furlano. Can you hear me?
I can.
Yes.
Great, thank you. So I think Dr. Oliver's comments are really salient ones in that it's not a standard recommendation that we screen workers, regardless of the setting, via laboratory testing. And I think part of the reason for that is obviously we don't have sufficient testing to test every person every day or even every week. There are some testing recommendations that have been put into place for congregate settings, nursing homes, where, for example, weekly testing might be more appropriate for screening. So what we've advised, and this is what CDC has advised employers to do, is to put other strategies in place. So screening for symptoms, face coverings, physical distancing, other kinds of mitigation that can help prevent. I think we all acknowledge that no strategy is going to create a zero risk environment. But I do think the combination of all of the mitigation strategies, so screening for symptoms, physical distancing, face coverings, limiting the number of persons in a room when that's possible, telework, access to testing when you are sick, strong policies that support workers being home if they are sick, so they're not having to choose between losing their job or staying home. So those things, but right now, that's what we would say there. There have been some larger employers that have considered more regular testing, and they could certainly take that on. I'm not sure the state has the resources to support those, what I would call very large workplace point prevalence surveys, but we would certainly support their decision to do that if they so choose. I think it's a good point that a test is a point in time, at least for now.
One further question is, it strikes me that, you refill a prescription, let's say, and the next month you're supposed to refill it again. You don't have to fight Anthem or whoever your insurance is to okay it again. And the problem, I think, for employers in this kind of mid-range is that to pay for 100+ employees one time is okay, but then it gets pretty prohibitive if you're trying to do every month to stay on top of it. And as it is now, of course, you've got to have a doctor know, you have to be symptomatic before you can get any kind of testing. Is there any connection to insurance companies that the Board of Health and the Department of Health might have in order to partner with them for ways to make it less burdensome on employers? Because the whole key is, of course, you want to get people back to work, and obviously all the precautions are being used, but nothing is perfect, and not even monthly testing. It's probably better.
We have started some conversations with the third-party payers. The impetus for that most recently has been the CMS recommendations for testing in nursing homes. So CMS has recommended weekly testing of residents in those homes and weekly testing of staff. And there's some parameters around that, but essentially that's what it is. So we have engaged Medicare and Medicaid, and I believe there's a conversation today actually happening with some commercial private insurers, even for that narrow space of nursing homes. And what I've learned to date for nursing homes is that Medicaid is likely to pay for weekly testing of the patients, but that the workers are considered, unless they're sick, that would be an occupational function as you're describing. So I'm not sure. Not sure if we're going to get much further than that, but I can definitely keep everybody posted. Because it's not a clinical recommendation, and frankly, it even is a clinical recommendation for the nursing homes, and even then, the payers seem very hesitant to commit to weekly testing of staff. So in that context, at a minimum, again, I would definitely strongly recommend all those other strategies are put into place to minimize the exposure risk.
Sure. Thank you.
Could I jump in with a question?
Can I pause this just for a second, Jim? We have been going for 2 hours and 20 minutes, and I think it might be time to go ahead and take our break here, if for no other reason than I'm going to have one. So let's break for about 10 minutes, get back as quickly as we all can, and we'll pick up right there. Jim, you will be third in line. It's Linda, and then Wendy, and then you, if that's okay. Jim?
That's fine, thank you. I just don't have a hand symbol on my smartphone. I'm sorry to interrupt.
Okay. No, you didn't. That was perfect timing. So we'll say get right back here at 11:30, and I'll see you guys as quickly as we can. Okay, it is 11:30. I hope most of us are back. In an effort to keep things moving, we'll go back to our questions. Ms. Hines, you are next.
Sure, thank you. And again, thank you, Dr. Oliver and the team for all that you're doing around the testing. And I really appreciate Dr. Villano's comments as well. And I did want to say we are in a little bit of a dilemma because I think that people don't currently understand the health guidance. We are getting many questions from employers on coverage of weekly testing. I mean, sometimes gone so far as to say daily testing. And this impacts not only the commercial insurers, but also the government payers as well. And so, you know, at this time, are we contemplating any maybe tighter guidance around the payment of testing and the healthcare guidance? Because I think that people, one, are not clear on the healthcare guidance, and as they're returning individuals to work, and they are asking for daily, weekly testing, which would really bankrupt the payer industry. I'm not sure that when you do this across the entire state of Virginia for all employers at all levels, if we could afford to do that.
I can start on that, Dr. Oliver.
Sure, go right ahead, Dr. Villano.
So we have heard this, and just this morning, actually, Dr. Walker Harris from the Secretary of Health and Human Resources office, she reached out to me because they're looking into some communications campaigns and across testing in general, but she actually reached out to me specifically around the needs, of the business community. I concur with you that there is some confusion out there about the guidance. VDH has a web page dedicated to businesses, which includes a lot of information, including a guidance document on essentially on testing and return to work and what the health guidance is. There are two strategies there for individuals that have become ill, so a symptom-based strategy versus a test-based strategy, and that's outlined there. However, we are aware that many employers are opting to exclusively use a test-based strategy. That's certainly their prerogative. However, the symptom-based strategy is also adequate, and it's included in the CDC recommendations. So I think what we need to do is better communicate that to employers and do a better job with informing them of the options there. I also think there's a lot of needed messaging to employers regarding sick leave policies, and that both CDC and VDH have statements in our guidance documents that essentially say that employers should not require a doctor's note or anything of that nature to verify their illness or to return to work, either due to a variety of reasons. I agree with you. I don't think it's reasonable to set forth what would essentially be, a prevalence testing for screening across the Commonwealth. I just don't think that's reasonable to expect that we would put out a recommendation that all individuals would be tested, weekly or serially like that. I don't think that's a reasonable approach. I know that's not what you're suggesting, but that is what we've heard from several employers. I don't know if you have anything to add, Dr. Oliver.
No, I think you covered it quite well.
If you don't mind, I couldn't unmute earlier, and I just wanted to add one more thing regarding the question around universities, just so folks are aware that VDH has been working with higher education throughout. We have a web page dedicated to higher education, and on that web page, there's a table that delineates the different roles of public health versus colleges and universities. Every other Friday, staff from VDH meet with the college and there's an association of college and university medical directors. Their next meeting is tomorrow, and we'll be doing kind of a deep dive with them on contact tracing and thinking through how to operationalize that and partner appropriately. So I just wanted to make sure we mention that. We also are working with them on testing strategies as well.
Thank you, Dr. Furlano. I think it is now Dr. Klein's turn.
Yes, thank you, everybody. A couple of questions. You've been talking about messaging and communications, and I know you're aware of this, but I have to go on record. So much of what you're doing is web-based and presumes access to Wi-Fi, presumes smartphones with data plans, presumes certain literacy levels. And so I worry about that for our most vulnerable populations, especially in the absence of libraries and schools, which are all closed. Which actually brings me to my question, which is, I know there are many variables, but can you briefly speak to the plans in place for reopening public schools and what public health efforts are being made?
I don't know if you can hear me, everybody.
Yeah, we can hear you. Dr.
Okay.
Furlano, I mentioned earlier, heads up our community mitigation work group and has been working closely with the Department of Education and the both at the K-12 and the university level. And so she's going to be the one who's best prepared to tell you about those plans, which we heard a lot about earlier this morning in a report to the governor's cabinet.
Thanks, Dr. Klein, for the question. So in regard to K through 12 education, I actually was anticipating some announcements to be made today, but I think other events, took priority at today's press briefing. So I anticipate that there will be more public announcements next week. We have been working with the Department of Education. There will be plans put forth for K through 12, including some kind of a specific guidance document around a phased reopening of schools, and the schools will likely be developing plans as to how they will implement CDC guidance that pertain to the reopening of schools. So we would expect those efforts to cover everything from physical distancing, health screening, gatherings, athletics, student health services, having a plan to isolate individuals if they're sick, how do they work with the local health department if there are cases or outbreaks that emerge, what are their triggers for dismissal, those kinds of things. So those plans should be published probably by early next week. The governor, I think earlier this week, announced that we are anticipating that there will be some form of if everything stays on track, some form of kids will be back at school in some way, shape, or form.
I just want to insert here before I let Jim move on that as someone whose county has a significant rural population, we're keenly aware that there are many people who do not have consistent Wi-Fi or internet available. But while our libraries and our schools are physically closed, many of them have maintained their Wi-Fi connections for parking lots, etc. And so some folks can check to see, in our case in Hanover, most libraries and most public schools have bumped their Wi-Fi connections a little bit so that you actually can go to a parking lot at a school or a library and connect to internet if you are not able to get it elsewhere. And I know that that's happening pretty consistently through the Commonwealth. It's not universal, and it certainly doesn't solve all the problems, but it is one opportunity for folks. Jim, Schuler, you are next.
Thank you, Madam Chair. My question would be directed towards Dr. Oliver or one member of his staff, and it would be in consideration of companion animals within and outside of a home situation. I've read and seen various articles regarding pets, and I'd like to know if there's any last minute clear evidence whether a pet could act as a vector, a carrier, or a source for COVID virus.
Dr. Solano may know more about on the literature on this. I've seen conflicting reports that I'd say the body of the evidence does not point to pets being a vector for this. I would caution us to realize that when we say this is a novel virus, that's really true. We first found out about it 5 months ago. So 5 months of history does not mean that we know all there is to know about this virus. So having said that there's not a lot of evidence that it's a vector, that doesn't mean that that's absolutely the case. That's what we know at this point. Dr. Solano, would you like to add anything to that?
I think that's correct. There is, we do have information about animals and COVID-19 on our website, and Dr. Oliver's correct. My understanding is that there's no clear evidence that companion animals like a pet could spread COVID-19 to people. There's multiple frequently asked questions on that webpage online, which I think would probably be helpful to you if you're interested in that.
Thank you very much.
Okay, Dr. Kinzer, did you have a second question, or is your hand still up from before?
I apologize, I didn't put it back down.
Oh, no, it's fine. I'm just trying to make sure everybody gets their questions addressed. Are there any other questions for either Dr. Oliver or Dr. Furlano? All righty then. Well, at this point then, the next item on the agenda is the regulatory update, which should shortly be displayed on the screen, and that is Mr. Hilbert.
Thank you, Madam Chair, members of the board. The regulatory action update and the accompanying spreadsheet was sent to you yesterday as part of the meeting binder, and the memo is up on the screen. This is our overview of our pending regulatory actions. There are currently 27 pending actions that are summarized there at the top of page 1. And again, a spreadsheet containing additional detail concerning each of those is attached to the memo, and you have that. Just as a way, a little bit of context, just as a reminder, the Virginia Administrative Process Act provides that certain types of regulatory actions are exempt from the standard requirements such as public comment and executive branch review. So exempt from the standard requirements of the state regulatory process. And that includes regulatory actions that are necessary to conform to changes in Virginia statutory law or the Appropriation Act where no agency discretion is involved. So I just want to remind the board of that. At the bottom, starting at the bottom of page 1, we have a summary of regulatory actions that were taken by the commissioner on behalf of the board since the December 12th, 2019 board meeting, when the board was not, while the board was not in session. The first is that the commissioner approved a notice of intended regulatory action pertaining to the regulations governing tourist establishment swimming pools and other public pools. These regulations are intended to protect the health and safety of patrons using water recreation facilities at Virginia's tourist establishment facilities. Our environmental health staff and the local health departments inspect these facilities for water quality and safe operation during their annual inspections of hotels, campgrounds, and summer camps. We previously did a periodic review of these regulations, and this regulatory action is intended to update the regulations with modern standards for health and safety at water recreation facilities. Turn to page 2. The Commissioner also approved a final exempt action to repeal the regulations for the licensure of abortion facilities. Chapters 898 and 899 of the 2020 Acts of Assembly repealed the statutory provision classifying facilities that perform 5 or more first trimester abortions per month as a category of hospital, thereby removing the regulation of such facilities from the board's statutory authority. Consequently, these regulations, 12 VAC 5412, will be repealed with an effective date of July 8th, 2020. Moving down page 2, the Commissioner approved final exempt amendments to the regulation for licensure of nursing facilities. Chapter 846 of the 2020 Acts of Assembly requires the State Board of Health to promulgate regulations that, quote, permit nursing home staff members who are authorized to possess, distribute, or administer medications to residents to store, dispense, or administer CBD oil or THC oil to a resident who has been issued a valid written certification for the use of CBD oil or THC oil in accordance with state law and who has registered with the Board of Pharmacy. So the final exempt amendments make that change to the regulations. The Commissioner also approved final exempt amendments to make the same type of change to the regulations for the licensure of hospices. So that same legislation from 2020 applied to both nursing facilities and hospices. So the board approved the Commissioner approved final exempt amendments to amend both the nursing facility regulations and the hospice regulations for the same purpose. Further down page 2, the Commissioner approved final exempt amendments to the regulations for the licensure of hospitals. Chapter 714 of the 2020 Acts of Assembly required the State Board of Health to promulgate regulations that, quote, establish protocols to ensure that any patient scheduled to receive an elective surgical procedure for which the patient can reasonably be expected to require outpatient physical therapy as a follow-up treatment after discharge is informed that he, 1, is expected to require outpatient physical therapy as a follow-up treatment, and 2, will be required to select a physical therapy provider prior to being discharged from the hospital. So the final exempt amendments make that change to the regulations. And in addition, Chapter 942 of 2020 required the State Board of Health to promulgate regulations that, quote, require each hospital with an emergency department to establish a protocol for treatment of individuals experiencing a substance use related emergency, to include the completion of appropriate assessments or screenings to identify medical interventions necessary for the treatment of the individual in the emergency department. So again, the final exempt amendments that were approved by the Commissioner make those 2 changes to the hospital licensure regulations. Move to page 3 of the memo. The State Health Commissioner issued an order declaring COVID-19 a disease of public health threat on February 7th, 2020. The other thing I would mention in the balance of the report, Madam Chair, is, as you know, we are required to do a periodic review of all of our regulations at least once every 4 years. We have more than 60 chapters in the Virginia Administrative Code, so we have a schedule for doing these periodic reviews. We currently have 14 periodic reviews in progress, and those are listed on page 3. And then the balance of the report on page 3 and over onto page 4 just summarizes for you the executive branch review activity completed by the Office of the Attorney General, Department of Planning and Budget, the Secretary, and the Governor since the December 12th, 2020 board meeting. So, Madam Chair, that completes my report, and I'd be happy to respond to any questions.
All righty. Are there any questions for Mr. Hilbert? I am trying to see whether there are raised hands. All right, it doesn't, whoops. No, it does not appear there are any questions. Thank you very much. So we have reached, I'm sorry.
I couldn't get the raise hand thing to go up fast enough. It's Benita. I do have a question on the, so the regulations governing dental scholarship and loan repayment program, it says proposed amendments. Is that something we've already reviewed or will be reviewing or will be seeing at a future meeting or?
Let me find that one on the spreadsheet. Just a minute, please.
Okay. It's your last grouping. It says the Department of Planning and Budget completed its review of the following regulatory actions.
Oh, sorry.
And it's the next to the last regulation.
Okay. So those are proposed amendments that were approved by the board at a prior meeting.
Okay.
They're now going through the executive branch review process. The Department of Planning and Budget has completed its review of those proposed amendments, and they are now pending in the Secretary's office. So the final amendments will come back to the board at a future meeting.
Okay. Okay. I remember doing something like that a few years ago. And so just was wondering if that was this particular.
I believe it was, yes.
Okay. Okay. Thank you.
All right. Is that it? Thanks, Benita. All right. We have reached the public comment portion of our agenda. As a reminder, you will be unmuted by the host when it's your turn to speak. In addition, all speakers are reminded that this is an opportunity for you to address the board on any topic of your choosing. However, it is not a question and answer period, and there will be no dialogue back and forth between speakers and board members. Mr. Hilbert, how many people are signed up to speak?
Madam Chair, we have 3 persons signed up to speak today.
All righty. Can you get us started with the first person?
Yes, Madam Chair, and just as a reminder, there are 3 persons signed up to speak, so I will be calling 2 names at a time. The first is the name of the person who will speak, and the second is the person on deck to speak next.
Okay.
So again, just pursuant to the board's policy, each speaker is going to have a maximum of 2 minutes in which to speak. If that 2-minute period ends while the person is speaking, we'll allow the speaker to finish the sentence that they're currently in the middle of, after which they will be muted and I will call the name of the next speaker. The first individual signed up to speak is Nandan Kankiraman, and on deck is Lana Grujicic.
Thank you very much. I appreciate the opportunity to speak to the board. I'm speaking to express concern over the orders of public health, which have been issued in part pursuant to an authority of the board, which is section 32.1-13. First, I wanted to laud the early planning and actions described by Commissioner Oliver, and I appreciate the vast scope of the issues discussed so far today. My concern is over the vast regulatory scheme that has shuttered businesses, restricted civil liberties, and vastly intrudes into the life of Virginians. I've sent a letter, a 4-page letter, to the board as part of this proceeding. I hope you review it. It's been over 100 days since Commissioner Oliver declared COVID-19 a public health threat. There has been no public comment period with respect to these laws, which subject businesses and citizens to criminal sanctions of up to a year. The board is initially authorized under 32.113, which is one of the sources of authority, and that makes the board responsible as for, kind of the operation of that section. I'm encouraging the board to stay in session to look at the orders. It was not brought up as a topic today. It's somewhat surprising since that is an authority of the board. And I'm asking them to bring some sense to this. I've provided some legal and other issues there. But the primary message I want to say is just that the board is responsible for section 32.113. The commissioner can operate kind of as an emergency matter, but a long-term regulatory scheme, is A, not appropriate, but B, if it's such a big story, then the board really needs to be involved in it and provide opportunities for these businesses to comment to the board. So thank you.
Thank you.
Thank you.
The next speaker signed up is Lana Grujacek, and on deck is John Tiggs. Sorry.
Thank you so
You're
much.
unmuted.
Thank you so much for allowing me to attend this meeting this morning. I really appreciate your time. My name is Lana Grujacek, and I'm a mother of a beautiful and strong 2-year-old boy. His name is Nikola Alexander Grujacek. And I'm here today to represent House Bill 97, which is to add Krabbe disease to the newborn screening panel in Virginia, so that hopefully no other babies have to suffer through this cruel disease that my son is currently fighting. For those that are not familiar, Krabbe disease is a genetic disorder that affects the central and peripheral nerve system. And those kids that are diagnosed with this awful disease, the prognosis is fatal. Currently, they're saying, the doctors have told us they have about 2 years to live after they first start showing symptoms. Nicholas started showing symptoms at 6 months. Up until then, we had nothing, not even a cold. He was the happiest, smiliest baby you would have ever seen. When we got the diagnosis at 6 months, we thought it was teething because he was crying. But the doctors told us it was Krabbe disease, and since it was already 6 months, there was nothing else they can do. But we were told to go home, take lots of pictures, have lots of memories, and love on him. Since then, Nicola just turned 2 in March, and we have been fighting to find a cure, to find answers. And one of the first things I asked our doctor is, why didn't we catch this sooner? And the answer was, we don't screen for Krabbe in Virginia. It's rare, we don't screen for it. Well, since then, I've met several families, and I've realized this disease is not as not as rare, but it is cruel. And there are several states that are screening, and I'm here today to hopefully add Virginia so that no more babies have to suffer.
Thank you so very much.
The next speaker is John Tiggs.
You're unmuted.
Great, thank you. Hey, my name is John Tiggs. I'm a small business owner in Loudoun County. We run a small farm and agritourism business, and we are being absolutely devastated by the inaction of this board to not follow what the procedures were started in terms of metrics. We've been in a downward trend now for over a month on infections and a very stable environment for hospitals. And yet this board is meeting for the very first time. And instead you forfeited your responsibilities to an unelected commissioner and a governor who is refusing to call the Congress or the delegates back into session. The net result is businesses are being destroyed all across this great state. And you guys haven't even asked the question today what the impact of these procedures are on businesses. It's time for you guys to step up to your job and to actually start to regulate the regulators. And if not, then the Congress needs to reassemble and hold you accountable. It's abominable to see the inaction of this board and the inability to realize the devastation wreaking across Virginia. I am finished.
Thank you for your time.
Madam Chair, that concludes the list of individuals who signed up to speak.
Thank you, Mr. Hubbard. With that, we move on to our regulatory action items.
So, Madam Chair, the next item on our agenda is fast track amendments to the regulations for licensure of nursing facilities. That regulatory text is displayed on the screen, and it will be presented to the board by Rebecca Allen from our Office of Licensure and Certification.
Madam Chair, members of the board, I am Rebecca Allen, the Senior Policy Analyst for the Office of Licensure and Certification. I'm here to present the fast track amendments for 12 VAC 5-371, Regulations for the Licensure of Nursing Facilities. The documents pertaining to this regulatory action were previously provided to you and can be displayed on the screen if you have any questions. In October 2017, a notice of periodic review was published for this chapter, and in response, no public comments were received. VDH also received and reviewed recommendations of VDH subject matter experts about changes to this chapter. Based on that information and analysis, VDH drafted the proposed amendments, which are before you today. This action is being used to conform the regulation to the statutes and to existing regulatory definitions, and no new requirements are being developed that did not already exist in statute. The following changes are being proposed. In Section 10, definitions have been added for barrier crime, criminal record report, legal representative, and sworn disclosure. Definitions have been removed for guardian and responsible person or party. Definitions have been revised for facility managed. In Section 30, license, language has been added about the non-applicability of the chapter to certain entities and facilities. Text has been revised regarding what constitutes an appropriate name, and text has been removed about notifying OLC about name changes, which is now found only in Section 110. The text has also been revised to more closely align with Section 10's definitions. Section 40, licensing process. The text has been revised to clarify that all nursing facilities must have a COPN, a Certificate of Public Need, prior to receiving a license. Text has been removed about modifications to the nursing facility that may impact the terms of the license, which is now found only in Section 110. Section 75, criminal records check. This is a new section that was created to include the statutorily mandated criminal records check, including language on how nursing facilities may satisfy this requirement when utilizing staff from temporary staffing agencies. The language about temporary staffing agencies is modeled on the hospice and home care organization regulations. Section 80, variances. The text has been revised to reflect that the Commissioner grants variances and to more closely align with Section 10's definitions. In Section 110, management and administration, language has been added about a nursing facility's requirement to inform the OLC of changes impacting its license. References to documents incorporated by reference have been updated, and the text has been revised to more closely align with Section 10's definitions. Section 120, governing body. Text has been removed about notifying OLC about changes impacting a nursing facility license, which, as previously mentioned, is now found only in Section 110. Section 400, unique design solutions. This section is proposed to be repealed. And the documents incorporated by reference section has been updated to reflect the changes in the proposed regulatory text and to reference the most current edition of each relevant document. In addition to those changes, the following sections were revised to more closely align with Section 10's defined terms and definitions. Section 60, on-site inspections. Section 70, complaint investigation. Section 130, Administrator, Section 140, Policies and Procedures, Section 150, Residents' Rights, Section 160, Financial Controls and Resident Funds, Section 170, Quality Assessment and Assurance, Section 180, Infection Control, Section 190, Safety and Emergency Procedures, Section 191, Electronic Monitoring in Resident Rooms, Section 210, Nurse Staffing, Section 260, Staff Development and In-Service Training, Section 300, Pharmaceutical Services, Section 330, Restraint Usage, Section 360, Clinical Records, Section 380, Laundry Services, Section 390, Transportation. Should the board approve these fast-track amendments, they will be submitted for executive branch review, which includes review by the Office of the Attorney General, review by the Department of Planning and Budget, review by the Secretary of Health and Human Resources, and review by the Governor's Office. After completion of the executive branch review, the fast-track amendments will be published in the Virginia Register of Regulations and on Virginia Regulatory Town Hall for a 30-day comment period. 15 days after the close of that public comment period, these amendments will become effective unless an objection is received from any member of the applicable standing committee of the House of Delegates or of the Senate, any member of the Joint Commission on Administrative Rules, or 10 or more members of the public. If such objection is received, this stage will serve as a notice of intended regulatory action, and the standard 3-stage rulemaking process is followed to promulgate the regulation. Madam Chair, members of the board, I recommend that the board approve the fast-track amendments to the regulations for the licensure of nursing facilities.
Thank you very much, Rebecca. So to get this underway, may I have a motion, please? Feel free to either verbally say your name and that you make a motion, or to raise your hand and I will acknowledge you.
Patricia Kinzer motion.
Okay, is there a second? And I believe I have Gary Kritzer as Gary. Are you the second?
Yes.
Okay, so I have a motion by Ms. Kinzer, a second by Mr. Kritzer. Is there discussion? I'm looking for your hands if there is. I do not believe I see anyone. I'm sorry. Mary Margaret, I do see. Mary Margaret, Ms. Whipple.
Yes. Thank you. I had just a background question. It says that the facility in the license section is not applicable to facilities established or operated for the practice of religious tenets. And I wondered if someone could explain that to me. What does that mean if it's established for the practice of religious tenets? And how many nursing facilities fall in that definition?
Thank you for your question. So the facilities that are established or operated for the practice of religious tenets, my understanding is that would be, for example, if you were to have a Catholic institution, for example, that is, for example, run by a religious order that only serves members of that religious order, they would be exempt. Now, because these facilities would be exempt from licensure, OLC, or VDH, I should say, wouldn't have numbers on how many of those facilities there are, because they're never subject to licensure. It's not a case of they apply for licensure, we determine they're exempt, and provide them with some statement of exemption so that we have a record that they asked for it. They are just exempt right out of the gate. So because they never interact with us for the purposes of licensure, we don't have a count of how many facilities that would cover.
So, Madam Chairman, may I follow up with that?
Please.
So who then is responsible for ensuring that they do, it says they have to comply with regulations on environmental protection and life safety. So who's responsible for that?
So to the extent that they would be subject to regulation elsewhere, that would be a different office within VDH. It wouldn't be the Office of Licensure and Certification.
Okay.
Madam Chair?
Yes, please, Joe, because if not, I'm going to follow up on Mary Margaret's question.
So we can follow up with our Office of Environmental Health Services. So in many cases, they would, if there was a food service in that type of facility, that there could be a separate permit through environmental health. So we can follow up with that and get back to you on that, Mary Margaret. Well, the other thing I would say is, and Rebecca can talk about this a little bit more. They may not be licensed by us, but they may still be certified by us for participation in Medicaid and Medicare, if they wish to participate in those programs, I believe. But in response to Ms. Whipple's questions, that would likely be through our Office of Environmental Health Services and the local health departments, particularly in terms of a food service permit.
I think I want to better understand that there could be nursing facilities that are purely religious based, over which we would have no real care auspices, and about the public harm that may cause. I think, Mary Margaret, does that reach to the center of your question? Because it creates one for me.
We're certainly concerned, especially right now, about our nursing homes and the situations there. And to think that there's some that are not licensed, I just was worried about how many might fall in that category.
Well, as Mr. Hilbert mentioned, there are, including these facilities, there are other facilities out there that are nursing facilities out there that do not require state licensure, but if they are participants in Medicare or Medicaid, there is federal oversight through the conditions of participation for Medicare and Medicaid. So while there is not a state licensure component, there is still federal oversight. And since the Office of Licensure and Certification serves as the state survey agency, there would still be medical facilities inspectors going in and evaluating the facilities. It just wouldn't be for the purposes of, do they meet the requirements of licensure? Are they meeting the requirements of 12 VAC 5371? Because they're not required to be licensed. They would instead be evaluated for their meeting the conditions of participation for Medicare and Medicaid. And these exemptions are, they're statutorily based. They're not ones that the subject matter experts in VDH had suggested. It was to conform the regulation to the statute, which exempts them.
Yes, I was quite sure of that. Thank you.
Madam Chair?
Yes, Dr. Oliver.
Just to give you an indication of the size of this issue, of the 267 or so nursing homes in the Commonwealth, there's only 9 of them that do not have certification with CMS. So,
okay.
So all but 9 of those nursing homes in the Commonwealth are subject to inspection by OLC, and we carry out those inspections and so on. And then that's in addition to whatever would happen from environmental health or other aspects of VDH that might be involved with inspections with respect to food service and that sort of thing.
If I might make one correction, I think the 9 facilities Dr. Oliver is referencing are licensed only facilities. So they only have state oversight. They don't have federal oversight.
Right.
And the remainder of our facilities are both, are licensed and certified.
Are there any other questions? I don't see any. Alex, could you do the roll call vote, please?
Sure. Mr. Kreitzer?
Yes.
Thank you. Mr. East?
Yes.
Thank you. Mr. Edmondson? He might be reconnecting his audio. Ms. Hines?
Aye.
You. Ms. Harrison? Okay. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Aye.
Thank you. Dr. Puritz? Dr. Puritz? Dr. Schuler?
Did you hear me say yes? I couldn't tell. I'm sorry.
Oh, yep, I got you now. Thank you.
Okay, thank you.
Thank you, Dr. Schuler, as well. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple?
Yes.
Thank you. And then circling back, Mr. Edmondson?
Yes.
Thank you. And Ms. Harrison?
She's still muted. She's still muted. Can we? She's raised her hand though.
We have her unmuted. Ms. Harrison?
Yeah.
Thank you. Madam Chair, the vote is 15-4.
All right, so
For the
12
motion.
VAC 5371 passes unanimously. Ms. Allen, if you could take us through the fast track regulation for licensure of hospitals.
All right, Madam Chair, members of the board, again, I am Rebecca Allen, the Senior Policy Analyst for the Office of Licensure and Certification. I'm here to present the final amendments for 12 VAC 5410, regulations for the licensure of hospitals in Virginia. The documents pertaining to this regulatory action were previously provided to you and can be displayed on the screen if you have any questions. Multiple sections in 12 VAC 5410 currently make reference to the 2006 edition of the Guidelines for Design and Construction of Healthcare Facilities by the American Institute of Architects. Two sections of the regulation further state that the Virginia Uniform Statewide Building Code takes precedent over the guidelines. As a result, the regulation does not conform to the requirements of Virginia Code Section 32.1-127.001, which states that, notwithstanding any law or regulation to the contrary, the Board of Health shall promulgate regulations pursuant to Section 32.1-127 for the licensure of hospitals and nursing homes that shall include minimum standards for the design and construction of hospitals, nursing homes, and certified nursing facilities, consistent with the current edition of the Guidelines for Design and Construction of Hospital and Healthcare Facilities issued by the American Institute of Architects Academy of Architecture for Health. In November 2013, a notice of intended regulatory action was published for this chapter, with the aim of revising the design and construction standards for nursing homes to conform to Virginia Code Section 32.1-127.001. In March 2016, proposed amendments were published and no comments were received in response. The final amendments before you today contain only minor changes from the proposed stage. The following changes are being proposed. Section 442, Obstetric Service Design and Equipment Criteria. In subsection A, the reference to the Guidelines for Design and Construction of Healthcare Facilities has been updated to the 2018 edition of the Guidelines for Design and Construction of Hospitals, and the references to the specific sections of the guidelines have been updated. The name of the organization issuing the standards has been updated. In subsection B, the first occurrence of labor, delivery, and recovery is short formed as LDR, and labor, delivery, recovery, and postpartum is short formed as LDRP. In subsection F, the abbreviations introduced in subsection B are used. Section 445, Newborn Service Design and Equipment Criteria. In subsection A, the reference to the Guidelines for Design and Construction of Healthcare Facilities has been updated to the 2018 edition of the Guidelines for Design and Construction of Hospitals, and the references to the specific sections of the guidelines have been updated. The name of the organization issuing the standards has also been updated. In subdivision 2 of subsection B, a typographical error has been fixed so that online is now a single word. Section 650, general building and physical plant information. In subsection A, the reference to the guidelines for design and construction of healthcare facilities has been updated to the 2018 edition of the guidelines for design and construction of hospitals, and the references to the specific sections of the guidelines has been updated. The statement that the Virginia Uniform Building Code and local zoning and building ordinances take precedent has been removed. In subsection B, language has been added about having an architect certify that the new construction and alterations are in conformity with the guidelines and the Virginia Uniform Statewide Building Code. Section 670, long-term care nursing units. The reference to the guidelines for design and construction of healthcare facilities has been updated to the 2018 edition of the guidelines for design and construction of hospitals, and the reference to the section of the guidelines has been updated, which has been added about having an architect certify that new construction and alterations are in conformity with the guidelines and Virginia Uniform Statewide Building Code. Section 1350, code fire safety and construction. The section has been named local state codes and standards. In section A, reference to the guidelines for design and construction of healthcare facilities has been updated to the 2018 edition of the guidelines for design and construction of outpatient facilities, and the references to the specific sections of the guidelines has been updated. The statement that the Virginia Uniform Building Code and local zoning and building ordinances takes precedent has been removed. Language has been added about having an architect certify that the new construction and alterations are in conformity with the guidelines and the Virginia Uniform Statewide Building Code. Subsection B has been removed, and the following subsections have been relettered accordingly. In subsection F, which is now relettered as subsection E, the citation to the Virginia Radiation Protection Regulations has been updated. In the Documents Incorporated by Reference section, the references to the guidelines for design and construction of healthcare facilities has been removed and replaced with references to the 2018 editions of the Guidelines for Design and Construction of Hospitals and the Guidelines for Design and Construction of Outpatient Facilities. Should the board approve these final amendments, they will be submitted for executive branch review, which includes review by the Office of the Attorney General, review by the Department of Planning and Budget, review by the Secretary of Health and Human Resources, and review by the Governor's Office. After completion of the executive branch review, the final amendments will be published in the Virginia Register of Regulations and on Virginia Regulatory Town Hall for a 30-day comment period. Upon the close of that public comment period, the amendments will become effective unless the regulatory change is suspended through a formal objection by the governor, through the governor requiring the agency to hold an additional public comment period, or through the request of 25 or more members of the public for an additional public comment period. If the regulatory change is suspended, the agency is required to hold an additional public comment period on the final amendments. Madam Chair, members of the board, I recommend that the board approve the final amendments to the regulations for the licensure of hospitals in Virginia.
All right, is there a motion to approve 12 VAC 5-410?
Dr. Purett, so moved.
Let's Hines, second.
All right, we have a motion by Dr. Puritz and a second by Ms. Hines. Is there any discussion and or questions? All right, I don't see any hands and I don't hear anyone. So Alex, can we have a roll call vote, please?
Faye, I have a question.
Okay.
Sorry, this is Jim. I have too many things to mute and unmute. I want to be sure that I understand specifically what is now taking priority. The state and local rules relating to building standards are now being fully preempted by these guidelines. Is that correct?
To the extent that there is a conflict between the local building codes ordinances and the guidelines, the FGI guidelines here, the FGI guidelines would supersede. That is correct.
Okay. Has there been any discussion with the organizations that represent the regulation, the building codes regarding this priority for the guideline rules?
To the best of my knowledge, there has not been a discussion, but the section of code that I quoted earlier, section 32.1-127.001, has in it that notwithstanding any other provision of law, that the guidelines take precedent. So it's a statutory requirement.
Okay. And so you haven't been hearing from anybody out there in the real world that they object to this?
We received no public comment on the prior stage, and we haven't received any outreach in the interim.
Thank you very much.
Is there anything else? All right, then, Alex, I would like a roll call vote, please.
Mr. Kreitzer?
Yes.
Thank you. Mr. East?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Aye.
Come on.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Piritz?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell? Oh, she's muted.
She was muted, but I could see her saying yes.
Okay. Ms. Whipple?
Yes.
Thank you. Madam Chair, it is 15 votes for the motion.
All right, we are, I believe, unanimous in passing 12 VAC 5-410. We now move on to regulations governing Virginia newborn screening services, 12 VAC 5-71. Jennifer McDonald is up. If anyone is not muted and is running a printer or something in their background, it's causing a little bit of interference, I think. Thank you.
Can you hear me? I'm sorry.
I can now.
Okay, great. Sorry about that. Thank you, everybody. Madam Chair, today I am presenting the board with proposed amendments to the regulations governing newborn screening services, which is found in the code 12 VAC 5-71. Section 32.165 of the Code of Virginia authorized the requirement to conduct newborn screening on every infant born in the Commonwealth of Virginia. Section 32.1-67 of the Code requires the Board of Health to promulgate regulations as necessary to implement newborn screening services. And the regulations are required to include a list of newborn screening tests pursuant to Section 32.1-65. The Virginia Newborn Screening Program aims to prevent intellectual disability, permanent disability, or even death through early identification and treatment of infants who are affected by certain heritable disorders and genetic disease. The Division of Consolidated Laboratory Services in the Virginia Department of General Services conducts the newborn dry blood spot screening test in collaboration with VDH. The benefits of the Virginia Newborn Screening Program includes that it makes it possible to find out whether newborn babies have disorders that may result in serious problems if treatment is not started soon after birth. Every newborn in Virginia is tested 24 to 48 hours after birth, unless a parent or guardian objects because the test conflicts with their religious practice. VDH newborn screening nurses coordinate follow-up activities until the infant is diagnosed, screened negative, or reaches 6 months of age. Babies who are diagnosed with certain heritable disorders or genetic diseases through newborn blood spot screening are referred to the Care Connection for Children screening centers for care coordination services. The rationale for adding 2 disorders to the Virginia Newborn Screening Panel are that spinal muscular atrophy, or SMA, is a genetic disorder characterized by weakness and wasting or atrophy in muscles used for movement and affects 9.1 out of every 100,000 births. X-linked adrenoleukodystrophy, or XALD, is a genetic disorder that occurs primarily in males, mainly affecting the nervous system and the adrenal glands, and affects 6 out of every 100,000 births. The additions of SMA and XALD to the newborn screening panel have been recommended by the Virginia Genetics Advisory Committee. And on the national level, these disorders have been added to the core panel of 35 genetic disorders included in the recommended uniform screening panel of the U.S. Secretary of Health and Human Services Advisory Committee on Heritable Disorders in Newborns and Children. Current regulatory provisions for the newborn screening program are contained in the regulations governing Virginia Newborn Screening Services, which is 12 VAC 5-71. VDH is requesting the board's consideration to amend the existing newborn screening regulation to add SMA and XALD to the newborn screening panel. Approval of this regulatory action would result in amending 12 VAC 5-71 to revise Section 30, which lists the specific disorders and genetic diseases that must be screened in Virginia. Currently, there are 33 heritable disorders and diseases on the Virginia Newborn Screening Panel. The addition of SMA and XALD will align Virginia's newborn screening panel with the national RUSP. All Virginia newborns would be screened for SMA and XALD at birth. The primary advantage of the proposed regulatory action is that screening for SMA and XALD can provide affected infants that benefit of early diagnosis and treatment. These disorders cannot be detected at birth through a physical examination. The main disadvantage of adding these screenings is the increased cost. Startup and operating costs for both SMA and XALD will be incurred by DCLS and will be supported by a fee increase for the blood spot screening panel that went into effect October 2019. The current fee is $138 per infant. The newborn screening fee was increased to $138 per infant in October 2019 to include SMA and XALD implementation. Adding SMA to the newborn screening panel resulted in an increase of $2.16, and adding XALD to the newborn screening panel resulted in an increase of $10.84 per sample, for a total of $13 for both of these disorders. An additional $24 was also included in the fee increase to support the implementation of congenital cytomegalovirus testing, as well as other newborn screening laboratory and follow-up operational expenses. Should the board approve the proposed regulatory action, the proposed amendments will be submitted to the regulatory town hall to begin executive branch review process, consisting of review by the OAG, DPB, Secretary of Health and Human Resources, and the governor. Following approval by the governor, it will be published in the Virginia Register of Regulations for a 60-day public comment period. Upon completion of the public comment period, CDH will prepare the final regulatory action for presentation to the board at a future meeting. Madam Chair, I recommend that the board approve the proposed regulatory action. Thank you.
All right, thank you. Do we have a motion to approve Virginia Virginia Regulation 12 VAC 5-71?
It's Benita. I make a motion.
Okay, we have a motion from Benita Miller, and who do we have a second?
Patricia Kinzer.
All right, thank you. So we have a motion from Benita and a second from Patricia. Are there any questions or discussion?
I just have one question.
I was just laughing at you having your actual hand up. Thank you. You go.
Sometimes it's hard to see the cartoon hand.
Totally got you.
So I just want to lend my support to this. Virginia's screening should be consistent with national guidelines, and I'd like to acknowledge the speaker and the public comments regarding this. I just have one question to clarify, who pays for the additional cost of the nursing follow-up and care coordination for these individuals who are diagnosed with this? Where does that cost get covered?
So, excuse me, I'm sorry, to clarify your question, you'd like to know where the cost for follow-up and referral to the care coordination goes to, is that correct? Comes from?
Right, because I understand the how we're going to cover the additional cost for the screening, and I'm just curious the additional cost for the care coordination.
So the care coordination is federally funded through care coordination centers through our Children and Youth with Special Health Care programs. Title V covers those operations.
Perfect, thank you.
Mm-hmm.
All right, are there other questions or comments? All right, seeing none, Alex, could you do a roll call vote, please?
Mr. Kreitzer?
Yes.
Thank you. Mr. East?
Yes.
Thank you. Mr. Edmondson?
Yes.
Mr. Edmondson?
Yes.
He said yes.
Thank you. Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard? Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Catherine?
Yes.
Thank you.
Thank you. And Ms. Whipple?
Yes.
Thank you. It is 15 votes for the motion.
All right, thank you so much. That passes unanimously. And we are now on to action items. Our first item is the state EMS plan, which will be presented by Gary Brown.
Yes, can you hear me okay?
We sure can.
Okay, great. Madam Chair, members of the board, my name is Gary Brown. I'm the director of the Office of Emergency Medical Services. I'm here today to present the statewide EMS strategic and operational plan. Section 32.1-111.3 of the Code of Virginia requires the development of a comprehensive, coordinated statewide emergency medical services plan. It also requires the Board of Health to review, update, approve, and publish this plan on a triennial basis. This plan was last approved by the Board of Health on March 16th, 2017, which is why we are back this year for the triennial approval. The statewide strategic and operational plan is developed in concert with the state EMS Advisory Board. This is a 28-member board appointed by the governor, and it represents all components of a EMS system. The section of code that I referenced also has 19 kind of generic objectives that we must address in the statewide plan. And it ranges from establishing a comprehensive statewide EMS system, incorporating facilities, transportation, personnel, communications, to promoting continuing improvements in system components such as ground, air, and water transportation, to conducting, promote, and encouraging programs of education and training and certification, to establishing an air medical evacuation system, to establishing a patient care data collection and performance improvement system, to designation of trauma centers and other specialty care centers. And I could go on and on, but that's just some of the objectives that are in the Code of Virginia as well. So the process that we use is very dynamic. The Office of EMS develops a template, and we share that with each of the 13 standing committees on the State EMS Advisory Board, and they are tasked to do a review of all areas that are within their purview of the respective committees. We also use outside documents and past reviews, such as the JLARC review of EMS in Virginia, the Institute of Medicine report, EMS at the Crossroads, as well as a 5-year strategic plan of the Federal Interagency Committee on EMS. So we look internally and externally in terms of the best plan for the statewide EMS system. And with that, we do, in the plan, we do have core strategies that are identified. Under each of the core strategies, we have strategic initiatives. Under each of those strategic initiatives, we have objectives. And under each of those objectives, we have identified action steps to implement the plan, and as well as accountability in terms of who is responsible for each of those action steps. And with that, Madam Chair, I present that to the board today for approval of the statewide strategic and operational EMS plan.
All right, thank you, Mr. Brown. Might we have a motion, please?
I'll make that motion. It's Gary.
Gary Kreitzer makes the motion. May we have a second?
This is Stacy. I'll second.
Okay, so we have Gary Kreitzer making the motion and Stacy Swartz making the second. Are there any comments or questions?
Madam Chair, it's Gary. I'd just like to reaffirm what Mr. Brown said, that this plan, I've been involved on the advisory board in the past, is thoroughly vetted by all the stakeholders in the Commonwealth related to EMS. And I want to thank Gary and his staff and the advisory board for their due diligence on ensuring that it represents the best of EMS in Virginia.
All right, thank you so much. Are there other comments or questions? Alex, can you do a roll call vote?
Yes. Mr. Kreitzer?
Yes.
Mr. East?
Yes.
Thank you. Mr. Edmondson?
Jim?
Yes.
I think that was a yes.
Giving a thumbs up.
Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Pierce?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple?
Yes.
Thank you. Madam Chair, there are 15 votes for the motion.
It passes unanimously. I have had a chat request for a break, so we will take 10 minutes now and we will come back and do the legislative update, the budget update, and other business. Let's try to come back. It's 1:45. Let's say we'll be back here at 1 o'clock. Okay with everybody?
Yes.
Okay, we are back with just a few other items to finish off. Mr. Helper, could you help us through the legislative update?
Certainly, Madam Chair, members of the board. I'll be walking you through, hopefully fairly quickly, just a brief summary of legislation that passed during the 2020 General Assembly session that the board may be interested in. Go to the next slide, please. You know, we've had a comprehensive harm reduction program for several years now in response to the opioid epidemic. There had been a sunset date on the board's authority to operate that program. One of our agency legislative proposals for this year, HB 378, removed that sunset date. That was the extent of our bill. There was legislative interest, however, in making other changes to the comprehensive harm reduction statute, really around changes that would make it easier and quicker to stand up comprehensive harm reduction programs around the state. So House Bill 791 was passed, signed by the governor, and just the big thing there in terms of accessibility to these programs, under that, the statute now no longer requires a letter of support from the local governing body or from the local law enforcement official prior to standing up one of these programs. However, and this was very important to us during the session, the state health commissioner still has the authority to approve or disapprove programs. So comprehensive harm reduction is alive and well, moving forward with various impediments to establishment having been removed from the Code of Virginia. And as I'm going along, if there are any questions, just please stop me. Another one of our agency legislative proposals was pertaining to expedited partner therapy for the treatment of sexually transmitted diseases. Previously, VDH practitioners had been authorized to provide expedited partner therapy. House Bill 1000 now opens that up to all healthcare practitioners in Virginia, i.e. physicians, nurse practitioners, and physicians' assistants. And the legislation also contained additional provisions, all intended to promote greater use of expedited partner therapy in the state. Next slide, please. House Bill 688 dealt with community health workers. For several years, the General Assemblies had interest in bills designed to promote greater use of community health workers in the healthcare system in Virginia. This past session, VDH was able to put together a legislative proposal that met with success. And under this proposal, under this bill, the Board of Health is now required to promulgate regulations governing the certification of community health workers. So you'll be seeing that regulatory action coming forward at a future meeting. Next slide, please. Another one of our agency legislative proposals was focused on sickle cell disease, which disproportionately affects African Americans. House Bill 907 directs the Board of Health to promulgate regulations for the establishment of an adult comprehensive sickle cell network. There already is a pediatric sickle cell network in Virginia that the health department is involved with. This legislation will extend that to adults, and there was an accompanying additional funding in the Appropriation Act to support this. Next slide, please. We actually had a lot of legislative proposals this year as an agency. This is another one, Senate Bill 386. This came out of our Office of Emergency Medical Services. Gary Brown and his staff had basically come to the conclusion that there were many opportunities where the greater use and greater sharing of EMS data could have proved valuable in many ways to strengthening the state's healthcare system, but there were very strict prohibitions in the code that prevented the sharing of that type of data. So Senate Bill 386 addresses that issue, and it authorizes VDH to share personally identifying information to certain entities that seek to improve the delivery of pre-hospital and hospital emergency medical services, the quality of patient care, and access to medical services, or to make other systems improvements. Obviously, the legislation creates guardrails and safeguards around this data sharing. This data can be shared only if the commissioner determines that such disclosure is necessary to develop and implement such improvements. It has to be in accord with applicable state and federal laws and regulations, and it also requires the Board of Health to develop and approve a policy specific to the sharing of data from the EMS patient care information system. So again, we'll be working on implementation of this as directed by the General Assembly. Next slide, please. So another one of our legislative proposals dealing with shellfish safety. We don't talk about this a whole lot as a board, but we do have a shellfish sanitation program that we administer here in the Health Department. This bill authorizes the designation of shellfish harvesting closure areas to be made via electronic means rather than having to rely solely on physical markers. So prior to this bill taking place, if you designated an area that was closed to shellfish harvesting, it had to be physically marked by physical markers. It had to be placed in the water. And this is not always possible to do or easy to do or feasible to do due to the water conditions and many other factors. And of course, technology now allows this to be done through other means, through electronic means. So this bill, which was passed, authorizes that. Next slide, please. House Bill 1090 dealt with childhood immunizations. So as we know, childhood immunization is a very hot topic in public health circles around the country. For several years prior to 2020, different pieces of legislation had been introduced that were seeking to add to the list of required immunizations for entry into school and daycare in order to close the gap between what was required by Virginia and what was recommended by the CDC's Advisory Commission on Immunization Practices, and there was a gap. Those bills always were defeated. This year, House Bill 1090 was introduced and met with success. And you can see on the slide that it adds certain additional vaccines to the list of requirements. It directs the board to amend the immunization regulations as necessary from time to time to maintain conformity with what's recommended. It also requires VDH and the Education Department to study the effectiveness of required vaccine programs. We did ask the commissioner, the governor, to put a delayed effective date of July 1, 2020. We did this in response to the pandemic and the fact that all the schools were closed. And in order to implement this, it requires a lot of close collaboration between the health department and schools. So the law now has a delayed effective date of July 1, 2020, which will greatly aid our ability to effectively implement this. Next slide, please. Another bill that I bring to your attention under the topic of maternal health, improving maternal health, is House Bill 687, which directs the Board of Health to promulgate regulations governing the certification of doulas, and this requires the establishment of a doula registry. Next slide, please. There was lots of legislation in the 2020 session focused on the safety of drinking water. So obviously we operate, we administer our Office of Drinking Water, which administers, we regulate all the public drinking water supplies in Virginia. We administer grant and loan programs to make health and safety improvements to local drinking water systems. Lead in water has been a big issue ever since the crisis in Flint, Michigan several years ago. Legislation was introduced and passed to require local school boards and daycares to submit testing and remediation plans for lead in potable water sources in line with EPA and BDH guidance. Test results are required to be submitted to the health department. House Bill 586 and House Bill 1257 were identical bills. These two compounds that are very harmful to drinking water that's been in the press a lot, PFOA and PFAS. We've had situations here in Virginia and Chincoteague and elsewhere where those contaminants were found. And what this legislation does, it requires BDH to convene a work group to study the occurrence and sources of contamination and recommend maximum levels for these two contaminants in drinking water. And finally, HJ 92 is requesting the health department to conduct a study of drinking water infrastructure in Virginia. So big issues, lots of work for our Office of Drinking Water to do over the coming months. Next slide, please. House Bill 1332 directs the board to promulgate a statewide telehealth plan as part of the state health plan. So we have, this will be a team effort within the health department. We don't have any one office or work unit that's really focused exclusively on telehealth. So this is going to be a combined effort between our Office of Health Equity, our Office of EMS, and also staff in the Commissioner's office here to work with stakeholders to put this plan together. The stakeholders are fairly well organized on this already, I would say, and that's partly due to the fact that as part of COVID-19, we established a telehealth work group within the Unified Command, and that is well represented by all the stakeholder groups that have a great interest in this. So we're going to use that stakeholder group as kind of a platform to build off of when we put this plan together. Next slide, please. Certificate of Public Need. As always, there was legislation this year on COPN. SB 764 passed. I'm calling this COPN process reform and limited deregulation. This is a very long bill. There are many details to it. Things that I wanted to bring to the board's attention was that there is a state medical facilities plan now, which, as many of you know, contains the criteria, the specific criteria that our Office of Licensure and Certification uses to determine whether or not there is, in fact, a public need as they review these applications. That SMFP is out of date. This legislation requires, first it changes this SMFP, it changes the name of it to the State Health Services Plan. It requires that it be updated every 2 years. It gives us a deadline of November 1 of 2022 to get that plan updated. You can see it does remove some services from the COPN program, and there are many other provisions as well. It also, the legislation also removes the cap on COPN application fees and allows the board to determine what the fees should be. So we'll be working on recommendations to bring to you for what that COP and application fee could be, because again, that's the source of our funding to administer the program and to bring the right staff on in order to get the SMFP updated within the time requirement. Next slide, please. So two other issues that came to the attention, appropriately so, of the General Assembly during 2020 pertaining to schools and school buildings was mold and Legionella. Senate Bill 845 requires each school board to create a plan for testing and remediation for mold in public school buildings. And Senate Bill 410, this slide is a little inaccurate, but I'll read it correctly. Senate Bill 410 requires each school board to maintain a water management program for the prevention of Legionnaire's disease in public school buildings. I don't know, you may remember, those of you in the Richmond area, there was a situation in Chesterfield School Division last summer, that created a lot of concern, and this legislation was in response to that. Next slide, please. Another significant issue that was considered and addressed this session was the prevention and treatment of sexual assault. House Bill 808 was passed, requires hospitals and pediatric healthcare facilities to have plans for either providing treatment services or transfer services to survivors of sexual assault, and directs the Board of Health to promulgate regulations for the standards of these treatment plans. And House Bill 1176 requires the Health Department to maintain and make publicly available a listing of certified sexual assault nurse examiners and places where they practice. Next slide, please. There was legislation focused on our newborn screening program. In 2020, House Bill 97 requires the department to review Krabbe disease and provide recommendations to the board regarding whether Krabbe disease should be included in the core panel of heritable disorders and genetic diseases for which newborn screening is conducted. So we'll be working on that. Next slide, please. As usual, there was legislation dealing with various aspects of our vital records program and the vital records that we are required to create and maintain. There was legislation in both the House and Senate concerning how to go about having a change of sex recorded on your birth certificate and having a new birth certificate issued. According to this legislation, changing sex on a birth certificate will require documentation from a healthcare provider stating that the person has undergone clinically appropriate treatment for gender transition. However, that does not require any evidence of an actual medical procedure. And then there was also legislation to remove from our marriage, divorce, and annulment records any indication of racial identification. So that is no longer on our marriage, divorce, or annulment records. Next slide, please. Bloodborne pathogens is a long-standing issue, long-standing public health issue, particularly among first responders and public safety personnel. So two pieces of legislation passed in 2020. House Bill 661 requires VDH to establish a work group to study and develop a plan to respond to exposure-prone incidents involving first responders. And House Bill 664 establishes consent protocols for testing in exposure-prone incidents involving first responders. Next slide, please. So, long-term care. So, anyone who follows the General Assembly even casually will know that every year there is legislation introduced to focus on staffing in nursing homes. And usually the approach is to try to impose in law a mandated resident staff ratio. That legislation has never been successful. Identical legislation was introduced this year. That legislation was amended in the Senate to what you see on the slide there. So Senate Bill 397 now requires VDH to convene a work group of stakeholders to create recommendations to increase the availability of the clinical workforce for nursing homes. So all I'm going to say about this is that this legislation was passed and signed by the governor prior to COVID-19. So I would say that this is going to be shaping up to be a really, really important study for the health department. And I think that the whole tenor and approach of this study is going to be changed drastically based on what's occurred. I think people's preconceived notions that they have coming in are going to change about what this study should be all about, what the issues are. So if any board members have any input that they want to share with us on that, I would love to receive it as we develop this study and put together a work plan for how it's going to be done. We are required to report to the General Assembly by November 15th. One other bill that I would mention on long-term care is Senate Bill 185. And actually I referenced this in my regulatory update. This is the legislation that directs the board to amend regulations providing authorization for storage and dispensing of CBD oil or THC oil to residents with a prescription. Next slide, please. There was legislation that was passed in the Senate, signed by the governor, asking the health department to look at issues pertaining to credentialing of healthcare providers, specifically tasking us to establish a work group to recommend creation or procurement of a statewide centralized primary source verification system for provider credentialing. Next slide, please. This was the legislation that was passed removing the board's authority to regulate abortion facilities, which we talked about. Next slide, please. Okay, so I was going to mention to you two new health workforce incentive programs that were created and funded in the Appropriation Act. The first one was dealing with a nursing preceptor incentive program, which funding was put into the budget to provide up to $1,000 incentive for any eligible provider who provides a clinical education rotation of 250 hours. So we were tasked with implementing that. However, in response to COVID-19, as many of you know, and Stephanie Gilliam will talk more about, coming back to the reconvened or the veto session, the governor put forth amendments to the budget that unallotted or took away many of the new sources of funding that had been approved when the General Assembly approved the budget. And this was among them. This is among the funding that was unallotted. So this is on hold. We're not going to move forward on this at this time because the funding is not there. Next slide, please. And similarly,
question about that.
Sure.
So just when in the discussions that you are planning on having, mentioned a few slides prior about nursing workforce, I wonder if this particular item might be included in that discussion by your work group, because again, this is all related, as you know, to nursing pipeline, and we have some major issues there. So just wanted to put a plug there.
Right, and for more clarity, when the governor sent his amendments to the budget down during the reconvened session, when he unallotted a whole long list of funding items. Along with that, it said that if there was, I'm paraphrasing, but if there was a report or a plan or a written document, a written plan that was attached, to be attached to that funding, then that planning, that reporting requirement is suspended as well. So the money and the plan and the money and the report are tied. So that's why I'm saying we're going to put that on hold for the time being. But yes, Dr. Kinzer, you're absolutely right. It is all related. And I'm sure this will come up and be discussed as part of the SB 397 discussions. And the next slide, please. And similarly, there was the General Assembly approved before they left town in March, the establishment of a behavioral health care provider scholarship and loan repayment program that was to be administered by the health department along with the various other scholarship and loan repayment programs that we currently administer. Again, the funding for this was also unallotted by the governor, so this is being placed on hold as well. Madam Chair, I know I went through a lot of information pretty quickly. I hope you found this helpful. I'd be happy to answer any other questions or comments that board members might have.
Does anyone have questions for Mr. Halbert?
I have a question.
Okay, just as you ask your questions, if you could just identify yourselves.
Whose turn? Whose turn it is?
Wendy, you go.
Okay.
And then Benita. Benita will be after you.
Okay, hi. So this is Wendy Klein. Joe, you mentioned House Bill 1176, which requires hospitals to provide lists, or I'm not sure who was required to provide lists of available forensic nurses, sexual assault nurses. But where did during the legislative session these past few years, there was attention given to the fact that there are geographic areas where there are no forensic nurses. And I thought there was a plan to study that or to remediate that. Was that unallocated? What happened to that?
Dr. Klein, I may have to get back to you on that. I can tell you that there were actually, so the two pieces of legislation that I put on the board were the two pieces of legislation that were focused specifically on the health department. There were other pieces of legislation also focused on sexual assault prevention that were passed that were focused on other agencies and gave other agencies responsibilities, including the Department of Criminal Justice Services. So there's quite a bit of direction and new responsibilities that came out of the session from the General Assembly to various executive branch agencies, not just the health department. So I will follow up on that for you. But if you can just repeat for me your specific question so I make sure I'm getting the right information.
What happened to what is the status of the legislation that was going to increase training for and the state capacity for forensic nurses? There are not enough of them, and I thought that there had been legislation that there had been a study group, and then I thought there was legislation this past year that addressed some of those needs.
There is legislation that we are required to provide some training now at the health department level. Looking for this slide.
I can follow up with you after.
Yeah, I'll follow up. Yep.
I want to thank.
I will get you that information.
I really want to thank you and everyone else. This has really been a very rewarding legislative agenda, and I thank you for all your hard work.
Certainly.
Hey, Dr. Miller?
Is there another question?
Benita.
Yes, I would say the same as echo Wendy's comments as well. And I do have 3 very easy questions to answer. One is regarding the community health workers legislation, House Bill 688. Can I just put a little, when you guys start looking at those regulations, consider some sort of oral health competency in there for those community health workers? Because I think, so often that gets bypassed. And it is so important, especially for children, but also for adults. But in particular for children. So just when we get started looking at those regulations or forming those regulations. Then on page 8, which is the immunization, House Bill 1090, I'm assuming that HPV for girls is already on the required list. I think it is, but I just want to make sure.
Yes, it is.
Okay.
It is.
It is required, but since it's not communicable, the school setting, it's not having it is not a barrier to entering school. So it's more of there's sort of an opt-out for it.
So, yeah, just to follow up on that, so the HPV for girls was already required, but the way that mandate is written in the code, it essentially, and I'm paraphrasing, but if you don't want your child to have HPV vaccine, you don't have to do it. So it's a very loose mandate. What they did in 1090 was they added boys to that same loose mandate that existed for girls. So it was really important when HB 1090 was being discussed, and this was a big fight in the General Assembly. I mean, there was lots of opposition to this bill. But one of the key questions was, and one of the key facts that was always stated was, this bill does not change any current exemptions. Okay, so it didn't take any exemptions away. It didn't add any new exemptions. It was simply adding to the list of required vaccines, but all of the existing exemptions still apply. So you still have your medical exemption, you still have your religious exemption, and you still have the very quote-unquote loose mandate for HPV that already existed for girls, but now boys are added to that.
Okay. Okay, and makes sense. But I'm just glad that that's being done. And then the last one is on page 19, healthcare provider credentialing, Senate Bill 365. And this, I'm asking this question as more as a point of clarification. Is this for healthcare provider credentials for applying for credentials for a hospital privileges, or what exactly is that?
This was focused on credentialing by health plans, by third-party payers. And the patron of this bill was Senator Donovan from Henrico, who is a physician herself.
Right.
And she had concerns that the credentialing process was too time-consuming and often repetitive and redundant. So that was the impetus for this.
Okay. Okay. All right. Thank you. Yes, and thank you for all your great work with our legislators.
Right. Anything else? Are we good with legislative?
Joe, this is Tommy. Can I ask a question?
Sure.
The dollars from the civil monetary penalties, are those funds so restricted as to how they're to be used that something like the nursing preceptor program, those dollars could not be used for that?
I'm not certain, Tommy. I'd have to look into that a little bit, but I can certainly look into that and get back to you.
Yeah, because of my understanding, there's quite a few. There's millions of dollars in that fund.
correct. Yeah, I'll have to look into that and find out what the restrictions are on the use of that money, and we'll let you know.
Thank you.
All right, anything else? All right, in that case, it is time for our budget update, and I think Stephanie has been waiting for us very patiently all day long. Stephanie, are you ready?
Yeah, hi, can you hear me?
I can. It's good to see you, or good to hear from you.
It's good to hear from y'all too. All right, well, good afternoon, Madam Chairwoman and members of the board. I'm going to be going over the various changes the governor and the General Assembly made to VDH's budget. I should note that, you know, the pandemic started when the GA was still in session, but they concluded before the full crisis kind of became apparent. So as you're likely aware, many of the items that were funded by the governor and the General Assembly have subsequently been unallotted. So instead of outright removing the items, they've basically been put, you know, on a hold for the time being. They did kind of add a note that if revenues recover, and that would presumably happen through either economic recovery or some sort of congressional action, that they could be reenacted by the General Assembly. They are planning a special session for later this year, but they could very well decide at that time to permanently remove some of the funding. But we'll just have to wait and see what the outcome of that will be. So since this is our current situation, I have included all of the approved funding in the presentation, but you're frequently going to see a note marking items as on hold. You're going to hear me say those two words a lot today. So next slide. So these two charts just show you the what VDH's budget was in FY12 versus what it's going to be in FY22 to kind of give you a comparison of how it's changed. You can see in the last decade, our agency has grown by about $200 million, the largest share of that being federal funds, but there has been growth in the general fund as well. Next slide. So this table breaks down next biennium's funding. So that first line there is the base appropriation that we had coming out of the last biennium. The next are increases due to central appropriation. So that's changes to salary, fringe benefits rates, and VETA charges that occurred in the last biennium, and they're now being made permanent. So the next line is about a $17 million increase to various non-general fund base appropriation. That's due to changes in federal grants and revenues that we basically had to ask for temporary increases for over the biennium, and this just makes those permanent. The next line you see is the new funding that we received from the session. Then after that, there's saving strategies, which I'll explain in more detail later. And next, you're going to see the amount that's been unallotted due to COVID-19. So any funding that was discretionary has been removed, which unfortunately is most of the funding that we were set to receive. But anything that was directly tied to legislation was left in place. Next slide. So first I want to talk about EMS's Trauma Center Fund. So a little bit of background, you may know about a decade ago, the driver's license reinstatement fee was doubled from $50 to $100, with the intent that the additional revenue be reverted to the state. A couple of years ago, Virginia made changes that impacted the reasons for which a person's license could be suspended, and they also set up a framework for getting people with suspended licenses restored. So it's taken a few years for those changes to impact our revenue, but FY20 has definitely seen a sharp decline, and we expect to see that continue on. The governor had proposed giving us $11 million each year for the fund, including in FY20, but we have had some revenues still coming in FY20. So the GA decided to reduce the amount we're getting this year down to $5 million, but they've not chosen to include anything for, they've, I think my slide is wrong, but so I don't believe there actually is funding for FY21 and 22. I apologize. But I will say they have removed any transfer to the Treasury because we were still set to, for FY20, have to revert that 1.9 million, and that's now been removed, and that reversion is gone for FY21 and 22 as well. So next slide. And let me apologize again at the front of this one. This is where I came up with my little marker to put on all the slides, but it doesn't actually belong on this slide. This one is not on hold because it just involves non-general fund. But this doesn't actually provide any new resources. It's just increasing an earmark from $90,000 to $190,000. EMS actually spends considerably more than that on background checks. But the amendment essentially requires EMS to pay for both certified and non-certified providers, where previously the language in the budget only had for certified. We did express concern that we don't have regulatory authority over the non-certified providers, and that currently that's the financial responsibility of the EMS entity, and that there's no regulatory definition of a non-certified provider. But nonetheless, it's now included in the budget bill. It's anticipated this is going to increase the number of background checks that EMS has to pay for, which is going to divert funds from other uses. So next slide. So the governor included in his introduced budget, BDH had requested $1.6 million in general fund to continue the Narcan distribution throughout the Commonwealth. We currently have $1.6 million in federal funding from behavioral health from the State Opioid Response Grant. The federal source had been set to end this September, but it's now been continued. So the GA has removed the general fund and replaced it with federal dollars instead. Next slide. So epidemiology received some general fund and non-general fund to cover the new additions to the required vaccines for children. Again, this is tied to a bill that was passed, so that funding has not been removed. We still maintain that. As Joe mentioned, it also requires the Board of Health to amend regulations for the immunizations to maintain conformity. I will note that any additional changes to the requirements in the future are likely to require more resources, which would mean we still have to go back to the governor and the General Assembly to request funds if anything else were to be added. Next slide. In state health services, or as we call it, family health services, first up, there's the language change that allows for the coverage of abortions in cases of fetal anomalies. That's now been restored. Up next, so the funding for the LARC program has been extended. BDH is currently doing a 2-year pilot this biennium, funded at $3 million each year. We only requested $2 million each year going forward based on kind of what we've been seeing as far as the usage. They're federal TANF dollars, but the GA did actually also provide us an additional $1 million of funds for other forms of contraception as well. So that's good news. Next slide. So DDH had requested funding for an electronic health record system again, but the General Assembly rejected the amendment. But they want us to go back and kind of take some more time to develop a more complete assessment of our need. So it's not an outright rejection, and we can still pursue this again once we kind of have more details worked out. So next, we've been provided $305,000 for adult sickle cell. As Joe mentioned, we currently do this for pediatric sickle cell, and it's funded at that same $305,000 level. And this was also tied to legislation, so that's not been impacted by the hold. Next slide. So the General Assembly also provided $250,000 for sickle cell patient assistance program, but as you can see, that one has been put on hold. Additionally, they'd also provided $750,000 for sexual and domestic violence fund, but that's also been put on hold. There was legislation to establish the fund, but just establishing a fund doesn't guarantee that it's funded, which is why that was still basically considered discretionary. Next slide. So VDH had requested $3 million for the tobacco cessation program, and the governor did include it in his introduced budget, but the General Assembly ultimately removed that funding. Next slide.
So a bill was passed that requires BDH to make information available on our website about the availability of certified sexual assault nurse examiners. So since this, again, was legislation, we are still going to get those funds. The next item is just an amendment that removes some outdated language. Next slide. For health equity, they had provided $150,000 in an FTE for a health and all policies position, but that is on hold. They also wanted to, as Joe mentioned, establish a behavioral health loan repayment program. They had provided $1.6 million, but that is also on hold. Next slide. Likewise, the nursing preceptor program they had hoped to create was going to be funded at $500,000 each year. That is now on hold. They had also provided funds in an FTE for a position to administer both that behavioral health and nursing preceptor programs, but that is also now on hold. Next slide. So FTEs and funding were requested for positions in Environmental Health Shellfish Division, as well as funds in an FTE for Wastewater Infrastructure Program Manager. Both of those items, however, are on hold. Next slide. So community health services, we had been provided funding for increases in the health district's rent. That's pretty typical, but again, it's considered discretionary, so that's also on hold. We'd also requested funds and FTEs for a 2-year pilot program for community health workers. The General Assembly removed the first year. The legislation that was passed to allow for the certification of community health workers led the GA to want to delay our program so that our community health workers will be certified. But again, this is on hold, so we will see. At the bottom of the slide, you're going to see there's a language-only amendment. It was just a technical issue. The introduced budget inadvertently removed all the language from Community Health Services section of the budget. The language outlines fees and other program details, and this amendment just fully restored that language. Next slide. So ODW's Environmental Protection Agency Drinking Water State Revolving Fund grant has increased in recent years, and BDH requested the general fund needed to match the federal funds. But unfortunately, this is also on hold. ODW does have the ability to leverage other funds to cover the unallotted state match, but that really isn't ideal. Next slide. There had also been funds provided for a data management system for ODW, but that is also on hold. At the bottom of the slide, you'll see there was a technical amendment done in financial assistance to community human service organizations, or we like to call them the pass-throughs. This corrected language issues as well as some dollar amounts that weren't annualized properly in the introduced budget. Next slide. So I'll just say in advance, all the changes in the pass-throughs are all discretionary, so they're all on hold. But just to talk briefly, the introduced budget had included $3 million for the Hampton Roads Proton Beam Therapy Institute. The GA reduced that to $1.5 million. There also would have been $30,000 for the Mel Lehman Free Clinic, but again, on hold. Next slide. So they'd intended to add another $1.5 million to the money we give to the poison control centers for FY21. We'll say the FY22 action is not on hold. What they did there is they removed the $1 million of funding that we have in our base for the poison control centers and replaced it with federal funds that belong to DMAS. So that pass-through becomes DMAS's responsibility in FY22. The second one on here, they would have added $100,000 for Special Olympics, which would have doubled the $10,000 that we currently provide to them. Again, these are on hold. Next slide. So as Joe mentioned, they did actually pass a piece of legislation for COPN, and it makes various changes to the program, and I'm obviously not going to read all of it to you, but I went ahead and included the entire summary, which takes up the next 3 slides, so that if you'd like the specifics, you can feel free to read through all of it. Please advance 2 slides. I will just say here, you can see they provided us $233,000 and 2 FTEs each year to implement the changes. And again, since this was legislation, we will still get this funding. Next slide. So in administration, first up is a language addition that requires mandatory reporting of temporary detention orders by private hospitals to the Board of Health, and that the data be shared with behavioral health. So the next one is a technical amendment that removes the $50,000 they provided in general fund for TDO tracking within the EDCC program, but the above change made this unnecessary, so they went ahead and removed the paragraph in funding. They did this for FY20 as well. Next slide. They removed the sunset date for the PANDAS Council. They also added a requirement to report on the agency's organization, operation, and changes to it. And VDH must make that report available on their website by August 15th of each year. The General Assembly required this of DMAS and behavioral health last session. So they evidently found it useful because they've requested it of us and DSS this year. Next slide. There was another technical that just removed some outdated language. They also added funding for the EDCC. They didn't actually provide us any general fund. They expect us instead to supplant current general fund expenditures that we have with our indirect cost recovery funds to free up the general fund to use as match for the federal grant. In the language added in the budget bill, they suggested a few possible choices to the federal funds, but without knowing exactly which grant it's going to be and the required match rate for that grant, it's hard to say that, you know, the $193,000 will be enough to actually match $1.7 million of federal funds. They seem to be, when they created that match rate, they seem to be thinking about the high-tech grant, which only had a 10% match requirement, but we don't even know if that's a viable option for this. So we will see how that will kind of play out. Next slide. As Joe mentioned, there were quite a few bills related to lead and mold testing in the schools and daycares. Again, this was tied to legislation, so we will actually receive this funding. This will know at the bottom, they plugged it into administration for some reason. Obviously, it doesn't belong in administration, but we can easily correct that. Next slide. So in the fall, we were asked to complete a savings strategy drill, otherwise known commonly as reduction drill, but they phrased it nicer. So 2 of our options were, yes?
No, I was just laughing a little, sorry.
Okay, it's all right. So the first one that they accepted, it increases our annual reversion from EMS's special fund by $2 million. So that particular pot of revenue was created when they did a $2 increase to the 4 for Life fee that's paid for your vehicle registration. So that fund has grown to the point that it was making over $2 million more than the current reversion of $10.5 million. So we felt confident that, you know, they could revert $12.5 million and we wouldn't have a problem with it, especially given like EMS literally has no authority to spend the funds generated by that $2 increase. So otherwise, it's not like they're doing the program any good. So they did accept that one. And then the other one we put up was a reduction in the general fund match for the high-tech funds we currently have. They had put in $370,000 of general fund and $3.3 million in federal appropriation, basically for the EDCC build out, the Emergency Department Care Coordination System. But the building phase is done, and the high-tech grant, in fact, ends at the end of federal fiscal year 21. So basically, the match just won't be required because that federal fund won't be there. So they also accepted that saving strategy. Next slide. Next slide. Previous slide. Okay, so another thing that the General Assembly has done is plug in that for FY20 we have to supplant nearly $1.8 million of general fund with our agency indirect cost recoveries. It's not an ideal scenario, but it is what it is. So next slide. So the next two slides give the details of the various non-general fund spending authority increases. And again, these aren't new funds for FY21. It's just making permanent those sort of temporary in-year increases that we've done over the last 2 years. I won't read them off to you, but obviously you have the full list here if you'd like to review it. Next slide. And here are the rest of them. And next slide. So there were 2 technical amendments done due to the creation of 2 new service areas. So the service areas were created last fiscal year, but it was done too late to actually make any changes to the budget. So all this does is move the resources that are currently in other service areas within our budget into the correct new service areas. So there was one created for the Population Health Initiative, and then we had one created for that cooperative agreement in Southwest Virginia. Next slide. And since I usually cover these, there were planned adjustments to state employee compensation, but like so many other things, it's been put on hold by COVID-19. So again, you can see that we had, going through the session, it seemed like VDH was going to fare pretty well, but with the unallotments, most of our new money is in kind of that on hold limbo stasis right now. This is no different. And next slide. Any questions?
Okay. Do we have anything for Stephanie? I can't believe the answer to this is no, so let me. I don't see anything. So Stephanie, as always, thank you for the very hard work that you've done and in giving us some very bad news as well as possible. Oh wait, Benita has a question. Benita, is that a question?
Jim has a question.
No, I'm good. Just scratching my head.
Okay. Okay, Jim, you go. That's okay.
Do we have any guidance yet about opportunities to supplement the numbers that Stephanie has given us because general fund revenues and other revenues might be somewhat higher? I'm sorry, can I not be heard?
No, I can hear you. Stephanie, can you hear Jim?
I'm not sure I understood the question.
Well, I'm just, you've given us numbers that seem to be current as of today. Do you have any indication that we might actually expect to get some supplements that would allow some of these unallocated line items to be reinserted in the budget?
I wouldn't say I'm terrifically hopeful for that. I mean, if you've been following the news on Congress, obviously, the House had passed a bill with the intention of giving funding to the states to replace their lost revenues, because obviously none of the funding they've passed to date can be used for that purpose. So, the state of Virginia got $3 billion from the CARES Act, but it literally states that it cannot be used to replace lost revenues. But if something should happen and somehow that bill or something like it makes it through the Senate as well, then obviously that would be a big change to the current, revenue outlook picture. So I feel like if something like that were to happen, a lot of these have a chance of coming back. But short of that, I'm not terribly hopeful.
Would we be able, if such legislation is forthcoming, or specifically with respect to any of the money that came to the state out of the CARES Act, has all of the money, all of the $3 billion from the CARES Act been designated for specific uses already, or is some of that potentially available specifically for the Department of Health's use relating to COVID?
So when it comes to the actual use for the COVID purposes and not for sort of anything that's been unallotted, that or GA intentions, there was a call put out to agencies to put in requests for that funding, and they are still largely being considered. We have already been approved for, I believe it's $58 million for contact tracing from that money, but that was kind of based, that one's already approved because it was based on an earlier decision brief that had gone to the secretaries, but all the rest of the funding was submitted kind of in separate requests, and now presumably the secretaries in the governor's office are compiling our requests along with that of other agencies to figure out what the needs are and what they can afford to fund. But we don't currently have an answer as to when we'll hear back on any of those requests.
That do it, Jim?
Yeah, that'll be relevant for some things I'm going to ask to talk about in a little while.
Okay, great. Thank you. Any other questions for Stephanie? Okay, Stephanie, thank you so much. Actually, we have a number of things under other business today, but I am going to start by asking Dr. Jabari to come back in because he had asked to have, I'm sorry? Dr. Jabari had asked to come back in to talk about some mask guidance. And again, if you are not muted, but you have other things going on, please turn your mute back on. Dr. Jabari?
Yes, thank you so much for allowing me to re-engage the board. We had an earlier discussion about the availability of general masks for the public. And I had, it sounds like I had misspoken in the fact that local emergency management officials do provide masks for a number of individuals outside of healthcare facilities, including essential government functions, governments, EMS agencies, local law enforcement, but it may not be for the general public. So I just want to provide that correction. And I know Mr. Kreitzer is immediately involved in this type of work if he'd like to chime in. I will certainly, I think as a lesson learned, we do have a bi-weekly PPE call with Virginia Department of Emergency Management. I'm happy to take the question posed about what can we do to help support the public, if any, in terms of providing additional capabilities. What I have heard is similar to when we prepare for hurricanes, we often encourage individuals to have a kit available, a ready-to-go kit. PPEs fall for the general public in the same category, where we oftentimes rely on the individual to take that responsibility. But in consideration that we have vulnerable populations, this is an EO that requires individuals to wear masks in public places. I'm certainly happy to take that discussion back to VDEM and look at it once again. So I don't know if Mr. Kreitzer would like to add any other comments as well from his experience.
Thank you, Dr. Jabari. The only other thing I would add is that certainly the local emergency managers will work with the community to try to provide where resources are for them to get masks. We've certainly been pushing out the information about how to make masks, at home. We've provided it to civic groups and church groups that are making them and giving them away. It's just that the local governments don't have the resources financially to buy them for the community. And what we're getting from FEMA and VDEM have very specific guidance as to what they can be used for. So, and we did receive some guidance previously that those masks for example, for the courthouses couldn't be provided to the public. Just to very specific parts of the court process. So that may change because some of that guidance seems to change on almost a daily basis, but that's where we are right now.
So
Thank you, sir. Thank you, Madam Chair.
Thank you so much. And if I can just add from a local government perspective, there are some localities, not mine, but there are some localities that are providing masks to their citizens. It is my understanding that Henrico County provided masks for citizens. And so one thing I think we might give as guidance is to have citizens ask their representatives whether or not that's something that they could help them with. And it seems possible to me that some jurisdictions may be able to help on a more limited basis. So I would advise, please go back to your representative in your county or your city or your town and see if that's something that people are able to do.
So, Faye, this is Mary Margaret. I can just give Arlington as an example. They have ordered and have now 50,000 masks. Some of them are for designated folks, but also some of them are for the public. But they're expecting people who are able to get masks to get their own.
Right.
These are for people who, for whatever reason, are not able to access them, whether financially or other reasons. And the social service safety net organizations are being asked, and faith organizations, to let the county know who needs them and or how many they need for the people they serve. And so there is a way for people that have special issues getting a hold of the masks to get them from the county. Also, we have a very good video from our county board chair about how to make your own mask from a square of cloth or bandana.
Well, and I would just say that what you're saying highlights my point that this varies from jurisdiction to jurisdiction. And the very best thing you can do is contact your representative in your jurisdiction to see what is out there. Catherine, you have your hand back up. Would you like to?
Yes. While I understand that this varies, from county to city, there's still people that are not going to go to the trouble of making a mask. And if you tell them that they have to wear one, if you don't provide them with one in some way, shape, or form, they're going to do something to try to get in the store that they want to go in. But the main thing that I wanted is Dr. Oliver still here?
Norm?
Yes, ma'am. I'm still here.
Okay, I know that COVID-19 has been pushed right off the front page, and some are in phase 1, some are in phase 2, but masks are still required by everyone going inside. Now, are we still in a state of emergency in Virginia?
The state of emergency is still in effect. It has not, the executive order that was issued on March 13th has an end date of June 10th.
Okay.
I don't know what the governor is going to do with that. We've been moving forward with the phases, as you've pointed out.
Right. Okay. Because we just don't hear much about it anymore. It's like, it's not relevant when we know it is. It is still with us. So thank you, Norm.
Thank you, Catherine. All right. So the next thing I want to do is I think I have either Allison or Robin here. All of you are aware of the citizen speaker we had this morning who conjectured that we were not living up to our authority or that we had relegated it. And we've had, I think most of you know, a letter yesterday. I think all of us understand that we are a policy board and that we have not inappropriately relegated our authority. But I want the AG's office to weigh in with at least just a brief opinion here to make it clear about what our role is and what is Dr. Oliver's.
Hi, this is Rabin Kurz. As you know, the board just meets 4 times a year, and under Title 32.1 of the code, the commissioner has the authority to act for the board when it is not in session the rest of the time. And he did, so he issued orders pursuant to 32.1-13. And those are orders given to, that authority to issue an order is given to him by the Code of Virginia. It is not a regulation that goes under the Administrative Process Act. It is an order, and my office reviewed the orders before they went out, and we're comfortable that he had the authority to issue those.
Thank you. I just wanted to clarify where we were from a policy perspective. All right, Jim, you had one thing you wanted to bring in here after Robin on another matter. Thank you, Robin. I think that's all we needed. Jim, first of all, I guess, does anybody have any questions for Robin before we move on?
Yes, I do. I'm sorry, can I be heard again? I'm sorry.
You can. Okay.
We received the letter from the gentleman who spoke this morning, but we also received a letter from a number of Republican state legislators who were demanding that we be a little more generous in opening businesses. Obviously, that's not our job, but it's because of who wrote those letters. Is it appropriate for us, either for you, Faye, or Dr. Oliver, to respond to the letters sent by those legislators?
Robin, that is for you to answer.
I think that is up to you. I believe the letters were to the board and not to Dr. Oliver. So I think it's up to the board whether it would like to provide a response.
Well, what I will say is this. I think we do not and probably should not have a vote on this, but maybe some consensus of the board. And if it is the will of the board that we respond to that, I will work with both Mr. Hilbert and the AG's office to craft an appropriate response.
I would suggest that we do that. I think that's better than simply not responding at all.
Faye, this is Patricia Kinzer. I'm assuming that the process would be similar to what we've done in the past, where you craft a letter and send out a draft to us prior?
Yep.
Great. I'm in support of that as well.
I am as well.
Yeah, me too. This is Catherine Waddell. I agree.
I am in support of that also, strongly.
Then I will work with Robin or Allison at their earliest convenience and try to get a draft out to you. It is Thursday afternoon. I'm going to aim for very early next week. And then, so Allison or Robin, could you just throw me out some times? I'm pretty much yours except for Monday morning.
Okay, we'll do that.
Okay, thanks so much. Okay, Jim, did you have something on a next topic?
Other business, yes, ma'am. This could take more than a few minutes, but I think it's really terribly important. Over the course of the last 10 days or so, I sent 2 emails to Dr. Oliver and Joe and Faye suggesting that some specific actions need carefully to be considered. I'm going to read parts of those 2 emails to you. They sort of serve as an introduction to what I'm going to suggest. This one I sent on Monday. It says, "Greetings from the bubble. I say that recognizing that those of us white citizens staying in suburban comfort, relatively speaking, are less able to express the depth of rage and frustrations that the Minneapolis horror has elicited from the minority communities. We feel it, just sadly, not quite so personally. My many friends on the right and the left are hugely upset by so many aspects of this calamity, causes, actions, reactions, concern for our entire society. When I sent the email that I'll get to in a second, a week ago, the murder of Mr. Floyd hadn't happened. Now the urgency of our taking action as a board seems heightened, and yet we are faced, as Stephanie fully described, resource constraints that we have to recognize. So what do we do? A question of our time for sure. Here's part of the email that I had sent a week before. At the risk of asking the obvious for the upcoming board meeting, I offer the following topics for Norm and the staff to address and for the board members to discuss, all of course related to the pandemic. Most significant, I think, are the ones that will get us ready for a subsequent pandemic or, heaven forbid, a recurrence of COVID-19. And I'm going to read some of these suggestions broadly, which I'd like to then have us consider as to how we might address them also broadly. And then I'd like to think about some specific actions tied to each one of them. Let's assume that the current administration has only 7 months to go. What programs should the department and the board recommend to the governor, our senators, and congressional representatives to reduce the disparities in health outcomes as revealed even more clearly by the coronavirus? What are the actions the department needs to propose to the governor regarding the next year's budget to make us better prepared for the next time? Stockpiles, training across specialties, training for National Guard, EMTs, and volunteers, protective measures for the most vulnerable, especially those in nursing homes and assisted living facilities. And here's one that I think is low-hanging fruit that I'd like us also seriously to consider. Shouldn't VDH, with larger hospital systems in the Commonwealth, identify underserved communities, both rural and urban, and open clinics in those places using state and hospital resources to improve access to care? Whether they are economically viable as freestanding facilities should be irrelevant. And that ties to the question I asked Stephanie a while ago about the use of some of these funds coming from the federal government. And finally, what will the Commonwealth and the department and the board need to do to make sure that we continue to attract and keep healthcare workers in the aftermath of the pandemic? Obviously, some of the things that Joe described earlier touch on this. Will the risks to the workforce shrink the number of nurses, technicians, first responders? Besides all of the justified public adulation, will we have to increase pay and benefits to keep these workers? Will we have to offer more training? Will we have to protect their households? Should daycare workers be a part of that group? I think it is our responsibility as overseers of the public health system to be aggressive in our response. That will include advocating for resources to make us better prepared and to close the disparity of health outcomes. I just feel this sense of urgency that is just so different even than it was a month ago. I would welcome a discussion of the topic generally and suggestions for me to press on with some specific ideas or to keep my mouth shut.
Jim, I'm going to jump in first, and then I'll let anybody who wants to come in after me. And I certainly am not going to suggest that you keep your mouth shut. But I am going to say this. It's 20 after 2. We did not break for lunch. It's been an exhausting set of data. And as somebody who's been in local government for nearly 20 years, I recognize the danger of trying to make sausage from the desk. And I think that you've raised issues that are far too important to try to set forth a set of guidelines here. And so what I might recommend instead is that our discussion focus on what are the specific items we'd like VDH to look at so that we can send them forward when they have a breathing moment after COVID. This is very urgent, but we are limited in our staff. To move on this with some alacrity when they are able. I think it would be a shame if we took people who are already overtaxed and gave them a very large job that there's just no way they could handle on top of what they're doing now. If anybody takes issue with what I've said, this is the moment to jump in. Or
this is Patricia Kinzer.
Yeah.
Is it okay? This is Patricia Kinzer.
Yeah, sure, Patricia, sorry.
I greatly appreciate what Jim has brought up, and my only concern with your response, Faye, is the phrase after COVID, because that's going to be quite some time. So I think that we actually need to address this ASAP, and I would volunteer to talk with Jim and brainstorm, and maybe there are others on this board that are willing to have conversations.
I'm just trying not to overtax the staff, that's all.
This is Holly Pure. Oh, I'm sorry. Go ahead. Were you still talking, Patricia? I apologize. I just want to thank Jim for bringing up what's been, I think, on many of our hearts, and it's certainly been hard to do business as usual when I don't even know the words to say how heartbroken I feel when I watch what's going on in our country, and I'm so embarrassed by who we are. So I think it demands really thoughtful recommendations to VDH, and I was also going to volunteer to be really happy and would want to work with Jim and anybody else to maybe formulate some thoughts and maybe be able to circulate it in an email to the board for their consideration to go to VDH. I think even the action of this being discussed at the meeting and the plan to do something is very meaningful and very important. To have any meeting these days with business as usual and ignore what's going on around us, it's like Rome is burning and we're talking about other things. It sends a terrible message to me, to the people that we represent. So I'm really glad that this will be in the minutes, and I think it deserves our really thoughtful efforts to try to all be better and make the health system that we're supposed to be caring about one that takes care of all of its citizens.
Great, and I hope it didn't seem as though I was trying to push this off. I just don't want to. I don't want to take it on fully in the 11th hour and not be able to do it justice.
I agree, but I do think it takes some time and thoughtfulness to do it right, and maybe that should be or could be offline.
Agreed.
I have a procedural question, because I imagine that there are more than two of us who would be willing to work on this, and I'm aware of our restrictions.
Meeting responsibilities.
Right. So how can we effectively work on this as a group using our combined brain power without having to do it two at a time? Or is that the only way we can do it?
I think I'm going to ask Robin or Allison to weigh in here. I think as long as we advertise this as a public meeting and we don't restrict others from at least viewing what we're doing, then I think we can do that. But I do believe we're under that we must at least advertise, and that other people must have access, but they don't necessarily have to be able to participate. Robin, did I get that close to right?
Anytime 3 or more of you convene, it does have to be noticed as a public meeting. But you do not have to allow another form of participation. But it could also, we can discuss the format, but I assume during this time it would also be electronic.
What I would suggest is not, maybe, hang on, Mary Margaret, I'm going to make you next. What I would suggest is whatever happens today, if we decide on some sort of subcommittee, that each of you may email me individually about your willingness to serve, and then we could get staff to do the advertisement for us. Mary Margaret, your turn.
Another piece of this is that much of this ultimately is going to be due up to the legislature, and they are the ones that have the, control of the budget and directives and everything, and legislation that governs the actions in the state. We could potentially, they're going to have a special session probably mid-August, something like that. I think we could write to them and tell them that, we have seen how gaps and inequities have been revealed by this crisis and how concerned we are, and urge them to look at their resources carefully in a way to help address some of these issues, even in the special session. And I know we don't know what the budget projections are going to be, and maybe there's no money at all. But this is clearly a huge issue that we can do better. But it will take resources, and they may need to be diverted from something else that in the current circumstances is less important. And then say that we, as the Board of Health, stand ready to provide, more thoughts on the topic and to think about this in a way that we can be of assistance to them.
Mary Margaret, do you think it's best if we approach the General Assembly with some very specific ideas that we have put together as a working group before we go to them?
Yeah, I think that might be better. And we can see how far we get along by that point. I mean, this is not a letter that needs to go this week. And the more specifics that we can include as at least examples, I think would be more helpful to them if we did that.
Right. All right.
A couple additional thoughts, Faye. Just.
Yeah, Jim, but I think there's a couple of people in front of you. Can I just recognize Catherine first and then come back to you?
Of course, I'm sorry.
Well, actually, I wanted to address Jim. I kind of wanted to know what he had in mind. Were you thinking of us doing something sooner rather than later, or something for the General Assembly? I'd like to know more about what your thoughts are on this issue.
Well, if I may answer.
Yes, of course.
For me,
yes,
time is of the essence. That the message has been received about both the need to prepare for the next time and the disparities, and I think we ought to be acting very soon. And what I was hoping is that we as a board and the department might have some specific recommendations. I hadn't thought about Mary Margaret's example of an August, say, abbreviated session. But I want to get us in the queue of priorities so that we, with the governor's help or the legislators' help, can get things in the budget in the next session. I mean, I absolutely recognize, Mary Margaret, of course, is absolutely right that the budget is in the hands of the legislature. But we got to get in line and hopefully to the front of the line for some of these things. And if I recognize that it's asking a lot because the demands are so great, but we need to get started on this process if we're going to be if we're going to be in the queue for the governor's proposals to the legislature.
So some thoughts about how to proceed from here. A working group? What, Linda?
Hi. I agree with all of you all's comments. I mean, this is really an important topic and issue that needs to be addressed. But I will tell you that one of the things that I feel is truly missing from all of this is, where is the information from the communities that we're trying to address the issue for? I think that many times we are rushing in with solutions that we think will help to resolve the issue. And I'm not by any means suggesting that we not continue to come up with solutions. But I also think a very important part of this is we need to talk to the communities that we serve. We thought that people weren't receiving care because they didn't have medical coverage. Medical coverage doesn't equate to access, but is access the issue? Are there available physicians, places for people to get? Is it an educational issue? I think we need to understand that to form our recommendations as well. And maybe that's part of the recommendations, to do some type of brief, not long projected study, but to get some of that information to help inform any initiatives. But I think that it does warrant quickly pulling together a work group to make some recommendations. In addition to that, I agree with Faye that, we don't want to take away resources. However, I know the Department of Health every day, along with the governor, they're looking at as changes occur, new information is coming in, formulating their plans. I think this could help them in their current plans, and I know that they're planning for future state as well. So I think time is of the essence. I don't think it will be taking away from what they're doing, but hopefully be an additive feature.
I don't know. I'm just going to throw this out here. Please, if it doesn't make sense, take it apart. I would think that those of you who are interested in being part of a work group could get your names to me by the end of business tomorrow. You either know that you can do this or that you're not. And then I will try to set up with staff to get a work group together virtually next week. Somebody help me.
I think that would be a great way to start, and then we can see where we go from there. And I think Linda's point is excellent, that too often in all of these public health efforts, we're talking to communities as opposed to learning from, and we have to think about who the messenger is and what the message is, and we have to learn from people who need the assistance or access to care, and not decide that what I think would work is what would work when I don't have that personal experience.
And maybe given the fact that, and this is Patricia Kinzer talking, maybe given the fact that many of us do have connections with community groups, if this is a publicly advertised meeting, perhaps there would be an opportunity for us to communicate with some people who might be willing to give a brief report about what they are seeing in their communities.
I am ashamed that I don't know a little bit more about what VDH's abilities are in terms of community engagement. I know that at VCU we have a number of scholars whose specific field is community engagement, and I've sat on those panels before, and they say exactly what you guys say, that the worst kind of community work goes to do some nice things for some poor people, and the best kind of community work goes into communities and asks them what they need and what they want, how they'd like to be helped. And I wonder if we might not benefit from just having somebody like Kathy Howard or Lynn Palco from VCU just talk to us for 10 or 15 minutes about community engagement.
I think it's a great idea, but rather than the concept of community engagement, I think what we're going for is actual community engagement. And I love them as people, but I think that I can certainly speak to what we're doing at VCU. There are several of us who are collecting data actively from various communities and have connections with them.
Okay, so you already have
that. I know that we could potentially call upon many of those people to chat with us if we wanted to.
So it sounds like a work group would be the way to start the ball rolling.
Can everybody who's interested let me know by the end of business tomorrow?
Happy to.
Yes, sir.
just send me an email and I will, I guess, send out a doodle poll for who's available when the following week. Or I'll just call you or you call me, but maybe in your email saying you're interested, you could let me know what your availability is next week as well. Would that work?
And then procedurally, so we don't have to inundate BDH staff with managing this, are we allowed to have a sub or a work group that meets? Like, do we have to use the WebEx platform and have to use their IT people that are supporting us? Or I'm just trying to think about what's the easiest. I'm imagining inviting community groups, and a lot of people are already using Zoom, for example, and have comfort with that, but not WebEx. And I'm just wondering if we have that flexibility to switch platforms.
Madam Chair?
And Allison, but I sure agree. Go ahead, Joe.
So again, if it's going to be 3 or more, the meeting needs to be publicly noticed at least 3 days in advance, 3 working days in advance, and the public has to have the opportunity. They have to be able to hear what's going on and see what's going on. That's the requirement. You don't have to have a public comment period if you don't want, but they have to be able to see and hear everything that the board members see and hear. The reason we didn't use Zoom for this and we used WebEx was I was informed initially through our Office of Information Management that Zoom was not really allowed by the state, by VITA. I think that may have changed a little bit. Marlene's saying yes. So I think Zoom is okay. But again, just the bottom line is you have to give the public at least 3 working days advance notice, and the public has to be able to see and hear everything that the board members see and hear. You know, for this meeting with WebEx, you can see how much time and effort went into making sure everybody could see and hear everything. So I'll just leave it at that. I mean, we're allowed to use Zoom, I guess. Is that correct, Marlene?
There are guidelines on security requirements that need to be configured before the call.
Right. So the reason that there is security from the state's point of view, from VITA's point of view, there are some security concerns with Zoom. That's why we have not used it to date for the board meeting. That's why we chose WebEx.
Joe, this is Allison. Correct me if I'm wrong, but isn't there also a requirement that a recording or a transcript of the meeting be posted as well?
Yes, Allison, thank you for that. There is a requirement. Today's meeting is being recorded, as we said at the beginning, and we're going to post that recording to our website along with the minutes. So yes, that is another requirement. Again, we can certainly help you with this meeting. That's part of our job. So we just need to think carefully about how we're going to plan it. That's all.
Okay. So I think what I understand this to be is that the earliest we could possibly meet would be next Thursday by giving 3 legal days notice. We need to advertise for that, and so would we use a VDH Zoom account? Is that
No, I think what they were explaining earlier is VDH doesn't have a Zoom account.
Well, the reason I'm asking this, sorry, Norm, the reason I'm asking the question is I have a personal professional account that I pay for. It is outside my connection to VCU, but it gives me many hours of open time, and I have the ability to record. So I'd be happy to do it on my account if that's allowed under the legal requirements.
Oh,
I don't know that there's a program.
I'm sorry.
Go ahead.
This is Wendy. What if Jim and Patricia confer, and then come up with some thoughts to share with Holly? We can do this perhaps sequentially. I gather the cutoff number is 3. Is that correct? So no more than 2 people can talk at a time, or can 3 people talk without having to go through all the procedures?
3 or more is
The
the
cutoff is 2. Cutoff is 2.
Yeah, I'm fine. I mean, I'm very interested in it, but I'm fine. Patricia sounds like she has lots of context. Jim certainly was the one with the idea. I'm more than happy, even though I voiced a lot of interest to, if that's easier to get the ball rolling quickly, to let the 2 of them, unless other, could move forward. It's more important we move forward than we get stuck in procedural issues. So whatever makes it move forward faster is, to my mind, the best choice.
So could the 2 meet and discuss, and then other members of the board individually email ideas, thoughts that we have to them to be considered?
No.
You cannot do that either.
Once you start adding people into a kind of a round robin conversation, at least from my local government experience, that can constitute a public meeting, and it looks as though you're trying to keep the public out of the public process. I think it's better. I think it's better to have a public meeting, and I am speaking for the attorney here. So Allison, please tell me if you think I'm wrong.
No, I think emails always get a little bit tricky. That's why we're constantly advising don't hit reply all to emails. So I would be cautious, and we would want to review that kind of approach if that's how you want to go.
Can I just ask a question?
Sure.
I know that we've already been accused of not doing our job as board members, correct? By these right-wing Republican members of the General Assembly. So now what are we doing? We're going to write them a letter. I'm not sure exactly what we're going to say in the letter, but now we're going to start having meetings to talk about COVID-19 and what we need to do in the future. How does that look?
I think it's a different thing, Catherine. I think we are not taking over Norm's job. And I think we have been letting Norm do Norm's work. And now we are a policy board. And so what we are doing is looking at where policy might be expanded to serve minority communities.
We all understand that. I understand that. You understand that. I just don't know how this will look. That's all.
We'll have to be careful how we frame.
And perhaps again, it's framing as each of us bringing who we are supposed to be representing. We are providing more voice. And so we actually are doing our job there in a way that maybe we weren't able to a few months ago when everything was going on and we were not able to meet in person. So to me, it looks like we are doing our job. But Catherine, you are more aware of how things can be twisted.
I am what? I couldn't hear you.
You're more aware of the context in which we are dealing with this. So
right. I'm just thinking how they're going to look at this. But I mean, I understand that we wanted Norm to do the job. I don't want that job, and he's done a great job. So, but we just want to make it better for the next time and for the people who were left out this time.
Right.
Question. Oh, sorry.
Go ahead.
My only question to Jim and Joe and Norm, well, maybe Joe and Dr. Oliver, did you all have a response back to Jim that we should hear as a board? Or do you all have thoughts about what would be helpful to VDH?
Well, this is Norm. Can you hear me?
Yes.
We certainly welcome input from the board regarding policy interventions that could aid the work that public health does in addressing the health care needs of minority communities in particular, and other underserved populations, rural populations and others. I would say that Jim's remarks regarding the harmful, the disproportionate impacts of the pandemic on these communities is certainly well taken. These health disparities are really a particular instance of the social inequities that exist in society, and I think we've talked about that periodically at the board. Everything from the lack of affordable housing to economic disadvantage, the low wage, poor jobs that these communities have, the under-resourced educational systems they have, and you could go on and on and on about that. The problems that these communities have to deal with day in and day out. And quite frankly, unless those sorts of things are dealt with, I think we will continue to see health inequities. So there's a very broad effort that needs to be made to eliminate social inequity if you want to really get rid of health inequities. And obviously that's something that will take a lot of policy work done at the state and national level, and a lot of action on the local level. These are things that we have been trying to address. The health department has joined with others in broad coalitions like the Partnering for Health, which we've reported to you, and looked at ways in which we could partner with healthcare systems, community-based organizations, faith-based organizations, and others to try to address some of these issues. The access issues that Jim raised are really critical ones, and we've worked with our partners in healthcare systems to try to address that. We've worked with the community health clinics and free clinics on trying to address those issues as well. As Ms. Hines pointed out, it's not just the access, like the physical availability of healthcare clinics and so on, but then there's also the issue of whether they're really accessible in a real way, right? There's issues of how the institutions are set up, the way they do conduct their business that may or may not make them genuinely accessible to these populations. The COVID-19 pandemic has, as we all know, really exposed for a lot more people to see than that these inequities in our healthcare delivery system. And we have found that that's provided us with some opportunities. Public health and primary care have been horribly under-resourced in this country, and it shows up in the fact that we have more deaths from COVID-19 than in any other country in the world. And it's saying something that a country as rich and well-resourced as this can't respond in the way that other countries can to a public health threat. And it's because we've had more than 100 years of neglect of public health and primary care. How do you resolve that? I'd love to get input from the board members on things that we can do, that we could propose in the next General Assembly. I suspect that it will be multiple General Assemblies before we actually start really doing things. But having said that, I think we need to start now. I'm not an ultimist in that sense. You know, it's like if a child trips over a broken sidewalk and scuffs her knee, I understand that the real problem is the sidewalk, and we need to fix the sidewalk, and we need to fix the structural stuff. But it's also true you need to pick her up, give her a hug, and kiss her boo-boo, and put a Band-Aid on it, right? So I definitely think we need to take some baby steps now to try to address some of these issues, but I want folks to really understand that we're talking about some major structural changes in the way our society is organized, and that's going to take a lot of hard work. I'm glad to hear that people want to tackle this problem, and again, look forward to hearing your suggestions, and know that our departments local health departments are doing a lot of work in this regard. Several of you were talking about community engagement, and our local health districts do a lot of work in community engagement. And I think whatever suggestions you bring to the table on these issues will be things that our local health districts will be happy to partner with you on to try to move forward. Those are my reactions to what was said.
Norm, I'm going to switch the conversation. Don't go anywhere. I'm going to switch the conversation just for a second because Alex has asked to talk about Zoom from a VDH perspective. So Alex, I'm going to let you go now.
Thank you, Madam Chair. I just received a message. So we tried using Zoom for an ECHO meeting that was held earlier today. And what I am told is that despite adhering to the VEDA security recommendations and requirements, there was a big hack that really pushed the meeting off course. And so that may be under revision again for whether or not we're able to use it or the feasibility of how to use Zoom. So I just wanted to share that with everybody as well.
Okay. So here's where I think we are. And I just see my job is trying to push along what you're asking for. Jim and Patricia will get together immediately and come up with some basic ideas and guides for a working group. And we will work towards everybody who wants to be a part of a working group, email me by end of business tomorrow, and I'll work with staff to try to see the best way to put that together. And then when we do have that meeting, that you two can lead the call. Am I anywhere near on track? And Jim, thank you for bringing this to us. Okay, anybody, have I got it way wrong?
No, I think you have it right.
Okay.
Yes.
All right, Jim and Patricia, are you good with that?
I am. I was about to say a minute ago that my pleasure. I think that's absolutely inappropriate term. It ain't a pleasure, but but I think it's our duty.
It's a pleasure to do the right thing. Patricia, you good with that?
That sounds good to me.
Okay, so that's where we go. You two connect up on your own. That is not a public meeting. And then everyone else just individually email me your availability and I will work with staff. Whew. Okay, I'm going to push us to the next thing. And the only next thing I have is we did not schedule traditional member reports today because of the constraints of the meeting. And it appears that that was a good idea. But there are a couple of members who have important reports that they wish to give. And so I'm going to open up for those. I know Gary has one, and I'm so sorry that I've forgotten who the other person was.
Hey, I can actually just email the report to you and we can send it out to the board for the essence of time. It's not anything critical that we need to report.
Is that okay with everybody?
Yes.
Okay. Does anyone else have a report they need to give?
This is Stacy. I can do the same thing.
Okay.
Just wanted to highlight what community pharmacist role was during this. It did have one kind of topic point that I wanted to mention that it doesn't have to be discussed at this meeting, but I want to make sure that it's on everyone's radar screen, is just we talked about a little bit earlier with the upcoming flu season, and there's clearly going to be a push to get flu vaccinations. And right now, over 20% of adults get their vaccinations in community pharmacies. And I think recent experience has shown that when the experts come out and say you should do this to combat the pandemic, people will go to their local pharmacy in mass and maybe create an unsafe working environment for pharmacists and pharmacies. So I'm looking to VDH to come out with good information on how we can have mass vaccination clinics in community pharmacy settings in a way that's safe. I know that I'm very concerned about it. I've had people ask me about when I'm going to have my flu vaccine just yesterday. So I'm hoping that that will be something that, because sometimes pharmacy can get forgotten in these situations. And I think that just keeping on the radar screen that this is a huge source of vaccination so that we can be safe looking in the flu season.
Thank you. And we will, if you would both just email me your reports, that would be great. Is there anything else that we have not touched today?
Faye, this is Mary Margaret, and this is absolutely not an official report.
Okay.
I do want you all to know that today is my 60th wedding anniversary, and I've so enjoyed spending it with you.
Well, this seems like an anniversary of sorts too, Mary Margaret.
Happy anniversary.
Happy anniversary.
Happy anniversary.
Happy anniversary.
I know, thank you.
He must have right out of the cradle.
Yeah.
Well, sort of.
What year is it for you guys, Catherine?
It's 59.
There you go. All right, everybody, I should have said this from the get-go. You people rock. I work with some good people every day, but I don't work with anybody that works harder or is more dedicated than this group. Everything that you do is appreciated, and I'm so grateful for it. Staff, you guys are, how you got us all through here, I do not know, but apparently we all can use a WebEx. So thank you all so much for everything. And I'm looking forward to talking to all of you very, very soon.
Thank you, Faye.
Take care. Thank you.
Bye, guys.
Bye-bye.
Bye.
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 Thank you, everyone, for logging on. We're going to end the recording and end the meeting now. Have a good one.
Thank you.